One live.
Good morning, everyone. Recognizing a quorum of commissioners, I'm going to call the February 27th, 2025 meeting of the Cannabis Control Commission to order. Meeting is being held hybrid pursuant to Chapter 2 of the Acts of 2023 and is being recorded. Commissioners Camargo, Commissioner Roy, and myself are participating in today's meeting. All votes taken today will be by roll call. We have a full agenda today that I will generally summarize. We will start each with commissioner comments and updates, a brief presentation from our Constituent Services Manager, Kate Fisk, before we begin the medical use of marijuana program public listening session. Following the public listening session, we will proceed to staff license recommendations. There are 2 changes of ownership recommendations and 34 license renewal recommendations. We have only 1 item under commission discussion and votes that is a job description for a data analyst. As luck would have it, they are also doing smoke detector and fire alarm testing in the building today. So we all know how much fun that can be. So I invite your indulgence. If noises start to go off, we will pause the proceedings until everybody can be heard. And then hopefully there won't be too many interruptions, but you probably saw the signage on the way in, just to caution everybody again, if all of a sudden there are loud chirps and lights and everything else going on. I will ask that commissioners wishing to comment or ask questions during any part of the meeting raise their hand to be recognized. We obviously are working through some technical issues, but I think we're good to go. And if you are invited to speak, you'll come up to the front of the table, sit yourself in front of the laptop and make your presentation. All right, with those initial comments, I'll turn things over to my colleagues for any comments or updates. I'm going to go in reverse order this time, and I will start with Commissioner Roy.
Well, good morning, Chair. Thank you. Good morning, everyone. I always look forward to these listening sessions. I'm so grateful to all of you for being here today. It's as commissioners and as regulators, it's vitally important that we hear from you as this industry continues to emerge and evolve. What was appropriate just a few years ago may not work today. And so I just want to say that, the medical program is near and dear to my heart. I've taken the time to go around the Commonwealth and give an educational presentation to older Americans about the medical program. And it's been a pleasure and a joy to do that. And with our former director of Constituent Services, Kathy Oliver Jones, and older Americans are quite curious, and we've always had great turnout and great questions. And I just want to take this time to acknowledge our team, our Constituent Services team. And they're going to present a wonderful presentation to you today about the breadth and depth of the program. But I want to take this time to thank Kate, who is the manager of the Constituent Services team. And I also want to take this time to acknowledge Wilfredo, Rebecca, Holly, Ian, Allison, Morgan, and Kiara for all their hard work. And just so you know, when you come here at any time, there's always members of the team, and they're hard at work on the phones. And we have just under 90,000 certified patients, and they last year alone tackled nearly 10,000 emails and over 40,000 phone calls. And they never rush anybody, and they always take the time to be compassionate and to listen. So we're at an inflection point in the medical program where we need to make investments in the program, right? We need to fine tune it, as you say, modernize, Chair, modernize some of these regulations that might not be appropriate anymore, but they were at the time. And how do we streamline some things to make access, increase access for folks. So we're here to listen to you today. That's the goal of this. And then that will inform our policy moving forward. But I just want to thank you all again. And I look forward to a very productive discussion with all of you. Thank you.
Thank you, Commissioner Roy. Commissioner Camargo.
Thank you. Really, I'm off mute.
Wait a minute.
Yeah.
So I'm off mute, but then you have to. Testing. Yes. Turn your audio down. Testing. Okay. All right. Commissioner Roy, thank you so much. I echo. Literally echo. Yeah, we're good now. Okay. This is interesting. This is really nice to be live with everybody here. Commissioner Roy, thank you for your comments. Folks in the audience, thank you for being here today. If you are staff for the CCC, can you just raise your hand? I see some. Okay, awesome. Thank you. So for other folks who are in the audience, you see who our staff is. If you have any questions, constituent services folks, can you raise your hand as well? Awesome. Thank you. Thank you. Thank you. Thank you for being here. I don't know who's answering the phones. Okay. All right. So thank you for being here. I'll just be very brief. I'm glad that we're doing this. As commissioners, we're sponsoring different topics throughout the next few months. And I was sponsoring this topic. Now it's everybody's topic. I want to thank Kate Fisk, who is the constituent service manager. Her and I have worked the last few days to create a visual for you all quickly on the medical program and constituent services here at the agency. I want to thank Andrew Carter, who is the agency's chief of staff, but he's also the supervisor of the constituent services department and medical program. So Andrew, thank you. And hopefully you'll say a few words when Kate is done with the presentation. I also just want to thank folks that are online. We apologize for the technical difficulties, but it happens. We're glad that folks are here. And then I just have a question for our team. So where did this come from? I see it on in our folder. Okay. Perfect. Perfect. My question is, will this be public information? Okay, after today. Okay, all right. So you all can't really see the screens right now, but if any of you want to see the PowerPoint that we're going to use for the next couple of minutes, it's really quick, but it is on our website. So you can go on your phones, go to the CCC website, today's board package, and you can follow along with that. I also say to the folks online. And with that being said, Commissioner Stebbins, I know you may have your comments, and then we can kick it over to Kate, and we'll be brief. And we hope that folks get a high-level overview of what this agency does in terms of constituent services and the medical program. Commissioner Roy, I always say I love when you pull out data and you give those points, but you said it in terms of emails and calls. So it's just going to be good to hear a little bit more about that. So thank you. Oh, I gotta go on mute.
I gotta lower my voice.
All set?
Yeah.
Okay, thank you. Just to echo my colleagues, the incredible team that we have in the constituent services office headed up by Kate, and still wish Kathy hadn't retired. She'd be here today. I know she saw this date on the calendar coming up. Obviously we're here. For me, I have deep concerns about the medical program. A stagnating number of patients, some MTC closures, declining sales for our MTCs, concerned overall about access. I know that was a conversation that we had when we had our hearing out on Martha's Vineyard last year, worrying about patient access to medical marijuana. So this is an important step for us to take. It's an important step for all of you to be here and offer your thoughts. And I want to just briefly give a shout out so we can move the program along, but I want to give a shout out to our constituent services team and to Andrew and the CCC team, and just express my appreciation for our counterparts at the Department of Public Health. Earlier this week, they came out with a memo which went out to physicians, certified nurse practitioners, and physicians assistants that are licensed by the State Department of Public Health. And it came directly from Commissioner Goldstein, a doctor himself, Have enjoyed working with him in my time here on the commission, but they issued a memo highlighting the benefits of the medical marijuana program, talking about how easy it would be for health professionals to join our program as well as patient information. So I just want to give a quick shout out and thanks not only to our team that worked with the folks at DPH, but to Dr. Goldstein and the folks at DPH for being a partner with us on this important topic. Commissioner Camargo, I don't know if you have any other points you want to make, or if you said them, or we can move right to
Be honest,
the presentation.
yeah, no, I have tons of comments, but I think in the interest of time, I think you all have said it, but we got to modernize this program. It's great in the beginning, but it's time to relook at this, and I would say rip up the regs and figure out how do we make this a more accessible and interesting program for the state of Massachusetts. I've talked about medical reciprocity with Commissioner Roy. We've been talking about that for years. So really it's time, and it's a good time. So I'm just excited about the process.
Okay.
Yeah, and if I may.
Sure,
Yeah,
Commissioner Roy.
and I just, want to thank chief of staff.
Thank you. Is that better? Pleased to introduce today
It's such an unmute.
You're fine now.
testing. Testing. Is that better? Okay.
Yeah.
So our team is comprised of Wilfredo Cabrera, Rebecca Carroll, Allison O'Neill, Morgan Stabile, Ian Gray, Kiara Wade Lee, and Holly Cantel. If they could just rise and just for acknowledgement. Thank you all. Thank you. These are the voices you hear on the phone, and in our email box here at the commission. These are the folks who respond to you, who attend to you. These are the folks who are the forward-facing voice of the commission. They have backgrounds in customer service, healthcare, teaching. They're from the industry. They really provide a holistic support to all our folks here. The constituent service department is truly a two-pronged department. We provide constituent support, and we also manage the medical use of marijuana program. Under the constituent service umbrella, we respond to inquiries from all constituents, and we provide resources, information regarding the commission's rules and regulations, sharing the work of each department. Under the medical use of marijuana support program, we support medical patients, enrollments and needs, and we also provide technical support on many levels to all of our patients, caregivers, providers, MTC agents, etc. Speaking more elaborately on the medical side, we really support cannabis as medication for our constituents. We provide advocacy, group connection, partnership with other agencies. We make resources more accessible for constituents. We help with understanding of products and how to purchase. We advocate for provider and patient communication. And we bridge the communication between constituents and commission departments. Next slide. Oh, on the live, we're back one slide. Thank you. Delving a little more deeply into the two roles, speaking specifically about the constituent support we offer, we also cover the operator phone line. So that's the main phone line for the commission here. We offer support for constituent communications that come through this line. Those are reviewed and are sent to the appropriate staff for follow-up. The operator line is managed by our reception and operations with a CSA team providing regular coverage and support. Is Kathleen Fleming in the room today? Or is she busily at? Okay, so she must be answering the phones. So Kathleen Fleming, she's part of the operations team, but we do take her as an honorary part of our team as well. She is the operator here, and she's the voice you hear when you call in to the main line. We do a lot of carryover work with her, and a lot of patients know that if they call into the operator line, they can find support there too when the operator line is not open. Under the constituent support umbrella, we also manage the forward-facing commission email box. So we triage and respond to all emails to the commission general mailbox. We receive and prepare general inquiries for all commission teams and complaints for the inspections team. And that email box is open for inquiries 24 hours a day, 7 days a week. And typically we respond within 24 business hours of all inquiries. This year alone, we responded to about 9,000 emails in 2024. In addition to those tasks, we also engage in stakeholder engagement in the field. As Commissioner Roy has sponsored and we enjoy, we've done some senior center engagement. We have done some engagement with NECAN, the social equity program. They've taken us out on the road with them a couple of times. We really appreciate getting out into the field and we look forward to doing it more. Additionally, we liaise with community and government agencies to support constituent needs. As Chairperson Sebbins talked about, we've done some work with DPH, and we look forward to that becoming really important in our work. And we hope that the recommendations are able to break down some of the bias for medical cannabis. Moving into the medical program support of our team. This is really where we shine. The medical program was established in 2012 under the Department of Public Health and transitioned here to the Cannabis Control Commission in 2018. This is where the Constituent Services Associates manage the phone lines. They take calls from patients, caregivers, healthcare providers, marijuana establishments, medical treatment center licensees, registered agents, and the general public. Anyone who calls in, we help them. We help them with whatever they need. We try to assist with their medical needs, or we try to help them with sending them to where they can be helped if we are not able to help them. So we really offer patient support related to cannabis, medical, anything related there. We help providers with their communication with patients related to their medical account, and we hope to reduce stigmas related to cannabis within the medical community. An average day for a CSA, something like that could look like patients, caregivers, complaints, licensees, anyone calling in for registration, certification renewal support, password resets, certification access, allotment, understanding, or review, access to MTCs. We could help folks find something in their community if they're not able to find it themselves. Communication between patients and caregivers and their provider. Sometimes that's difficult for folks. We talk to veterans who need assistance with their accounts. We talk to court-involved individuals who need immediate assistance for their needs, who need records. We talk to marginalized individuals and low-income folks who need help with accessing low-income or like lower-cost certifications. We talk to state advocacy groups. And we truly help patients and caregivers and anyone that needs assistance navigate our program. Just a couple of days ago, on 2/22, we received 229 calls. That's between 10 and 3 o'clock. And that's on both the operator line and on the patient support line. On 2/25, we received 135 calls. The call volumes vary, but the investment in the patient need does not vary. We take our time. We get what patients need. We see them through to the completion of their question, and we hope that their needs are met. Additionally, on an average day, we check the commission inbox throughout the day. We approve online applications, reviewing all the needs, and then we approve or send them back for more information. And then we also review and approve paper applications. In 2024, we processed 1,601 paper applications. Additionally, we are starting to incorporate registration in-person events. So folks can come and see us either here. We're hoping to have them in additional locations in the community where we can help folks do hand-over-hand in-person registration. So we can, people who aren't able to access our system or need some additional help with our paperwork, we can help them in person. And we're also hoping to have more educational events where we pair with SCP. We recently created some rack cards with the help of our comms team and the SCP program so that we could have some additional resources for events like that. Next slide, please. Just this, oh, one back, I'm sorry. Just an overview of our numbers. In 2024, we had 13,549 registrations. Renewals, we had 73,621. And for caregivers, we had 1,944. And in renewals for caregivers, 4,798. So a patient can have up to 5 caregivers. A caregiver can have 2 patients. There's no cost for any registration here in Massachusetts. And a caregiver is able to access to support a patient. They can access dispensaries together and possess medical cannabis and purchase on their behalf. You can see our calls. We had the patient services inbound, so calls had about 29,530 calls, and we were outbound, so calls returned for messages. We had 6,166 calls we returned to patients, caregivers, other constituents. On the operator line, we had 6,676 calls into our to the front end, and we had 387 calls returned out from that line. The average time for waiting in the operator line is 1 minute and 33 minutes, and for the constituent line is just 3 minutes and 23 seconds. So not very long, in my opinion, for that many amount of calls in a team of 7, who may not be a team of 7 every day, based on different needs of the team. Next slide, please. Here's a review of our commission mailbox numbers. In 2024, we processed about 8,271 emails. The green emails are strictly related to medical marijuana. So we categorize everything by color, we tag them, and we file them. So green is for medical, red is licensing, orange is investigations, and there's other ones here too, press, government affairs. Every department has a different color, but you can see the more heavier ones are there. We can go over other ones if there's specific questions. That's really all I have for you. In our next slide, if we could just proceed one more slide. I do have contact information, how to contact us. Our general inquiry and comments can be sent to our front line, or you can contact the medical use program directly. And our email is always open, so you can contact us there. We also have a whole host of information on our general website for the commission. You can find patient information, caregiver information, provider information. We have how-to top 10 items. There's many really good resources there. All of our documents are in paper that come in English and in Spanish there. So if you ever have questions about any of that, you can certainly call us and we can walk you through that as well. Thank you.
Thank you. Thank you, Kate.
Thank you.
I just have a question just for edification.
Sure.
So on the Constituent Services Department by the numbers, so I see patient registrations 13,549. This is for the calendar year 2024.
Yes.
What is paper applications process? How is that different than a patient registration?
So that is part of the patient registration number, because those are part of it. It's a separate line. So we offer paper applications to folks who can't manage our online support or like our online system.
Oh.
We also offer paper applications for folks who don't have proof of residency. So if they have the proper documentation for identification but can't come forward with a proof of residency document, because that's part of our regulations, we are able to send them a paper application. They send it back, and then we process it that way for them. So paper applications are something we utilize in that purpose as well.
So it's like for folks that might not have access to computer and that you still, okay,
Yeah.
just wanted to clarify. And then can you explain what the difference, what is calls offered?
Those are calls that come in, and then calls handled are the total of the inbound and outbound. So calls,
say that again. So
calls
are
are offered in, and calls handled are the total of the inbound and the outbound.
Okay, thank you.
Thank you.
Comment?
I guess I'll take myself off mute. So comment, thank you so much. While we were working on these numbers, you know, I had a lot of aha moments, and even though I've been working here for long, we don't know everything that's happening in every single department. But you all are the front line, whether emails or phone calls. And of course, a lot of folks email us as commissioners. So I just want to say thank you to the staff who's here, who's been, you know, here for years, but also the new folks that have gotten here in terms of this department, because I didn't realize how front line and engaged, you know, you guys were. So I just want to say that. The other thing is, having worked in the criminal justice system for a lot of my career, it was good to also hear that we provide court-involved folks with support. You know, and I hadn't thought about that. So I'm glad to hear that as well. I'm big on the reentry community, so I appreciate that. And again, I just want to say thank you for giving us these numbers, the visual. We're going to look through this stuff as well. I hope that this goes online as well so that folks can look at this. And I know that we're not perfect and we have work to do in terms of the medical program, but this is really helpful. So those are my comments, and I don't know if Andrew has any last comment.
Sure, absolutely. If I may, Mr. Chair. Yes, well, Kate, thank you so much for your presentation. You have done a wonderful job representing the team and our work. So I just want to say thank you to you, to all of our team members who are here. Thank you so much for the work you do every day. Of course, to our medical patients and our constituents. I love hearing from you all, and I look forward to continuing those relationships as well. So thank you all so much.
Thank you, Kate. Thanks, Jen.
Thank you. Thank you for your help.
Thank you, Kate.
Thank you very much.
Nice job.
Thank you.
I would be remiss. Many of you know we had a meeting on Tuesday to walk through our research department's state of the industry report. And I would direct a lot of you to go and read that report, but there is some new research that was included in that report about the medical program, about age of patients, where most patients are, you know, kind of lining up in Commissioner Camargo's age bracket, maybe not my age bracket, as well as the, you know, the purposes that a lot of folks are reaching out and entering the medical program, and what illnesses or anything else that they're trying to, you know, use cannabis to offer them some relief. So invite you all to go and see the industry report again, which we just reported out on Tuesday. All right, that said, we'll move. Go ahead.
I just want to give you all a minute or two, if you don't have to sit there for the rest.
Not a drill. It's just a test.
All right. We've gotten one of those out of the way. Hopefully won't be too many more of these. We'll move into the public listening session on the medical use of marijuana program. First, some housekeeping guidelines for those wishing to testify. If you haven't already signed in, please add your name to the sign-up sheet in the back. Jessica, you're still taking anybody who hasn't signed up? Please see Jessica in the back of the room. We will take testimony in order of how folks signed in. If there are any elected officials who wish to testify, we invite them to go first. I'm not seeing anybody in the room. Again, first we'll hear testimony from those who are in person before moving on to those who will testify virtually. Please be advised that when we will be switching over from in-person to virtual testimony, we'll have a brief recess so we can set up the virtual testimony. In order to allow as many people as possible to testify, we will be limiting testimony to 3 minutes. Speakers are invited to come to the podium at the front of the room, introduce themselves, what entity or organization that you may represent. Speakers may be asked follow-up questions at the discretion of the commissioners. The commission asks that speakers use respectful language, speak to the topic of the commission's medical program. The commission encourages speakers to submit your testimony in writing as well. For those who cannot attend this public meeting in person, written testimony is always welcome regarding the medical use of marijuana program and may be submitted to commission@cccmass.com with the subject line regulatory amendment testimony. All right. We'll start with the list. And again, I'm going in the order that people signed up. I would invite Jeremiah McKinnon from MPAA to come forward and testify.
Good morning. My name is Jeremiah McKinnon, and I'm the President and Executive Director of the Massachusetts Patient Advocacy Alliance. Enough is enough. For too long, patients have been left behind. For too long, the medical program has been neglected, overlooked, and in many ways set up to fail. The Commission has the power to change that, and I'm here to demand that you do. While minor adjustments have been made, the fundamental issues threatening the viability of the medical program remain in place. The medical program is hemorrhaging, and the Commission is debating how many Band-Aids it'll take to stop the bleeding. But we don't need Band-Aids. Patients need real access to their medicine. And there's one change, one decision that I think could stop the collapse of the medical program. Let dispensaries sell medical marijuana without forcing them to grow it themselves. Forcing every dispensary to grow their own plants is the single biggest barrier to patient access. It piles on costs and complexity, effectively blocking most operators from the medical market and leaving patients with fewer places to get their medicine. There are almost 400 recreational dispensaries in Massachusetts, and yet there are only 93 medical dispensaries, all because you won't let dispensaries serve patients unless they're vertically integrated. If equity is truly your goal, this is a strange way of showing it. Recreational dispensaries are everywhere. They're already selling cannabis, and they could connect to the medical portal and serve patients, but you won't let them add a medical register because they don't grow their own plants. This isn't about business. This is about patients. Every dispensary in this state needs to be able to sell cannabis tax-free. Every community where cannabis is sold needs to have access to the medical program. And yet entire cities, entire regions of the state have no medical dispensaries. Cambridge does not have a single medical dispensary. Boston lost 3 of its 7 medical dispensaries last year. While recreational shops multiply, 12 medical dispensaries closed in the past year. Patients are worried if the next dispensary to shut down is the one that they rely on. If forced to use a recreational dispensary, they're being taxed on their medicine. By refusing to fix this, it begs the question, is the goal to help patients or to profit off of them? This is not regulation, this is neglect. The Cannabis Advisory Board recommended in 2018 and 2023 that you eliminate the vertical integration requirement. Last year at the listening session in Martha's Vineyard, MPA warned this commission that failing to eliminate the vertical integration requirement would only buy time, not fix this problem. And now, those 234 patients that you were so worried about losing access, they're literally on an island with no access to medical marijuana at all. This was preventable. Martha's Vineyard was the warning. Don't let it be the fate of our entire program. You have the power to fix this. Don't wait another year, another month, another day. There's no time left. Listen to the patients here today and the vertical integration requirement. Give us a medical program that works, not tomorrow, not soon, but now. Thank you.
That is Frank Shaw.
Thank you, Jeremiah, for your testimony. And I have the
fortunate opportunity to serve on the Cannabis Advisory Board Research Subcommittee, which Jeremiah is a member. And he always is well-informed and brings lots to the table. And we are, for those that don't know, the Research Subcommittee is in the process of formulating recommendations as well around the medical program. We had a robust conversation last week, and we will continue to contemplate thoughtful recommendations. So I just want to thank Jeremiah for his contributions.
You're safe, right?
All right. Good morning. My name is Frank Shaw. I am 72 years old, medical marijuana patient, and a member of the Massachusetts Cannabis Advisory Board since 2021. In 1998, I was diagnosed with HIV/AIDS, and I'm lucky to be alive today. The medical marijuana movement started with HIV/AIDS patients who were suffering and dying. In the 1980s and 90s, we fought for access to this medicine so they would not be treated like criminals and treated with respect. Now, decades later, my access to this essential medicine is under threat. Why? Because the Cannabis Control Commission is letting the medical program collapse due to neglect. 12 medical dispensaries have closed in the past year. And what has the commission done to counteract this? Nothing. Despite this alarming trend, the commission has refused to eliminate the barriers that are holding the medical program back. Medical operators are forced to show $500,000 to apply for a license, forced to become vertically integrated, and must pay a $50,000 licensing fee per location. Meanwhile, recreational dispensaries are not held to this same standard. No wonder the medical program is failing. If medical dispensaries are disappearing and new ones cannot open under these harsh conditions, how can this program expect to survive? That's why I'm calling on you to update the medical regulations. Let every dispensary add a medical register today. Every dispensary and every delivery operator should be able to sell cannabis to patients tax-free. And before you try to claim that the law requires vertical integration, stop. It doesn't. It's just an excuse to use to push this issue aside and dismiss the hardship patients face. You have the authority to eliminate this barrier. What are you waiting for? This is an emergency. Patients are losing access as we speak. You cannot continue to ignore this crisis. It's time to eliminate the barriers. Because if you continue to do nothing, there won't be a medical program left. What are patients supposed to do? What am I supposed to do? We're out of time. You need to step in and fix this now. Thank you for your time and indulgence.
Thank you, Frank. Any questions?
Thank you, Frank.
Thank you, Frank. Our next speaker is Carrie Sheehan. Carrie here? No. We'll come back to Carrie. Next one, and I'm going to apologize with some pronunciations of last names. Michael Latulip. He's not here? Okay. Move on to Bill Downing.
Yeah. Okay. Right on. My name is Bill Downing. I live in Reading, and I've used medical marijuana since 1985. I'm here to represent a typical medical marijuana patient. Massachusetts citizens in 2012 voted to allow those who are ill or injured access to marijuana as their doctors recommend. The primary principle of medical cannabis program is access, yet access is going away due to regulatory neglect by the CCC. There have been numerous closings of medical cannabis dispensaries, and there's a general lack of access. Lack of access forces patients to pay taxes on their medical cannabis or resort to the black market, and that is a shame. Patients should not pay taxes on any cannabis purchases. Patients should be able to show their medical card at any cannabis dispensary and not be charged for their purchases. All cannabis, even cannabis sold at a recreational dispensary, becomes medical cannabis when a patient uses it. Let's recognize that reality. Many, if not most, ill or injured citizens survive on limited, often fixed income. Considering how easily and inexpensively marijuana can be grown, it should cost patients nothing at all. Instead, patients paid the very highest prices for years. Prices are lower now, but being forced to pay taxes on medicine that should, by all that is right, be free adds insult to injury. Shrinking access requires patients, often with limited mobility, to travel from town to town or even county to county to access affordable cannabis. For many patients, cannabis delivery is not available. Social equity businesses cannot even hope to enter the medical cannabis market due to the costs of vertical integration, high fees, and initial capital requirements. Their financial exclusion clearly violates Chapter 180. Medical equity does not exist anywhere, even in economic empowerment areas. Social equity businesses should not have to pay licensing fees to add the service of patients. Patients are at the highest risk of health issues due to contamination. Dangerously, most contamination issues, as you know from the research report yesterday, have to do with medical licensees. The medical cannabis program is about access for patients, not the generation of revenue, and it must be properly funded. It should be funded by cannabis tax revenues, not from fees. Patients have been ignored and are frustrated, while medical cannabis businesses we depend upon crumble all around us. We watch the CCC spending time and effort on superficial matters like lottery tickets. What about patients? This is a medical emergency.
Next up is Tim McNamara.
Thank you to the Commission for holding this. It's been a while since I've been able to speak to you all about the medical program, and I do appreciate the opportunity. Been very busy. Some of you have met me at our facility, Holistic Health Group. I'm the president and general counsel there, DBA, Suncrafted. You're familiar with the location. Commissioner Stebbins came by, Commissioner Roy via phone. Commissioner Camargo, open invitation. We have another pitch contest coming up for a disproportionate impact, so you're invited to that as well. So I come from more of an operator's perspective, and I sympathize with the patients who spoke today, and I think that the recommendation they're making is a sound one. I think there's more that can be done as well, and I'd like to speak a little bit more from a licensee's perspective. So despite recent reports about the sustainability of the medical program, as you're hearing today, and as Commissioner Stebbins has said, I don't think that it's as healthy as the report indicates. Patient counts are down, license, we're losing them, and they're closing every month, and revenues are on a steady decline. This is not really a criticism necessarily exclusively to this commission or this state. It happens in every state. Adult use cannibalizes medical, but it's something that here in Massachusetts, especially since we're known as a hub for life sciences, medical research, there's just so much promise that, you know, really inspired my entry into the cannabis market to begin with. So I think the commission needs to take a proactive approach to fight these economic forces, or whatever forces you might deem them. How to help, I think some of the suggestions today, the deverticalization can be helpful. Reciprocity was mentioned, that's also going to be important. The fees, I'm probably the only person in the state at this point who's trying to open another medical dispensary at this point. More on that later. But that dispensary is going to be a $50,000 licensing fee every year. So we already went through this once. We spent over $250,000 in provisional while waiting for a final license. We don't want to do that again. I think that it should be brought into parity with the adult use program, i.e. if an adult use dispensary standalone or co-located is opened, that should look very much like the adult use dispensary fee. Likewise, you know, the revenues from adult use at this point are 12 times what we're seeing in medical. So the fees just really don't make sense in this thing. Another one that I'm very passionate about, and I've been seeking guidance from the commission for over 6 years on, is the caregiver institution regulations. I'm not sure if the commission is familiar with that. This is essentially where the dispensary is allowed to sell or distribute directly to hospitals, long-term care institutions, and hospice centers. I have been speaking for the last 2 years to a number of these institutions at conferences. They're ready. I mean, last fall I spoke to the American College of Healthcare Association at their conference in Portland. These people are already seeing cannabis in their facilities. They want to know how to get access. They want to know how to form policies. Again, this state stands on the front lines, and we can really be a power in this. I'm very ambitious to make sure that access gets to these people who are not ambulatory, who don't have the regular ability to get to a dispensary, especially in an end-of-life stage. I also wanted to talk about some other underused regulations. So, you know, we don't have to create more and more regulations. There's a lot of regulations that already exist that are just not being paid attention to. Something that was really interesting to me when adult use regs first came out was the leadership program. What about proactively working with your licensees to find who's a champion for social justice, local employment, energy and environmental concerns, and medical treatment centers? We're constantly seeing bad news from people who are criticizing these issues, but what if the commission takes it upon themselves to exercise those regulations and celebrate the champions? Who is a good employer? Who is doing something unique about social justice, and who's doing the right thing for patients as a medical? I would love to see that happen. It's one of the most innovative set of regulations I've seen as an attorney in my career. So please look at that. Lastly, and this is not restricted to medical, I don't know where my time is, but still have some time. The accounts receivable situation in this state is abhorrent. The writers of the regulations spent a great deal of time trying to control for every ill that the industry might face. They're tracking plants from seed to sale. They're making sure everybody passes a background check. They're making sure that every square inch of the facility is covered by cameras. But does the company pay their bills? Who knows? I can get cited for a deficiency because a plant tag is touching the soil. And if I don't pay $30 million to people who I owe money to, it's not a deficiency at all. This is business. I mean, and this is killing the industry, because once one bad actor doesn't pay their bills, that affects every good actor down the line. And that's what you're seeing today in this price compression. There is a lot to be said for that. I had an inspection in October. 7 inspectors visited. Very nice people, very patient. We have a good relationship with our investigations team. And yet I'm saying to myself, if one of those persons just stayed behind and monitored who was paying their bills, it would be so much more effective to find out who can sustain in this industry, who's going to support the other members of their community in this industry. So those are my main recommendations. I could speak to you all day, as you know, about other issues, but I do appreciate the opportunity. I'm happy to speak more about some of these things if given the opportunity, and thank you again.
Commissioner Roy, go ahead.
And,
Mhm.
mentioned, Portland, did you mean Maine or Oregon?
Maine. Yep.
Okay, can you talk to us a little bit about what they're doing up there, just briefly?
Yeah, I paved over that very quickly. This was a conference of the American College of Healthcare Association. So this is a group of healthcare administrators in long-term care facilities. I was invited to speak to the conference that was held in Portland in October. And so at that conference, I described to them, how access to cannabis is available in Massachusetts, what the present status is, and what stands to happen in the future. And that's where I covered the CCC regulations that allow for caregiver institution delivery. Everybody was very excited. Of course, the federal question is one that stands tall in everyone's mind, but still private institutions have that availability as well. So this was me speaking to a group of people who manage nursing homes, essentially. And likewise, I've had these conversations with hospice centers, the Massachusetts Councils on Aging. This is the group that manages all of the councils on aging, where everybody has these questions now. All these people are looking for how do we get access to the aging? Councils on Aging are constantly working on access to communities for all kinds of things, meals, everything. But cannabis is among those where their clientele can't travel to a dispensary easily. So we're trying to find ways to make sure that these people who are homebound or in an institution can have access to cannabis. No. Well, I think that not officially. So Maine does have a different variation of the caregiver program, but I was speaking to a New England regional group. Yeah, so it just happened to be in Portland, which was a nice trip or whatever. But yeah. So.
Thank you on the accounts receivable. We're very mindful. Acting Chair Stephens and myself have had multiple meetings with sister agencies who have already implemented and with the help of other industries, the alcohol industry, for instance.
Yes.
There was prohibition in alcohol, just like there was prohibition in cannabis, and it took them decades later, I think the 90s, for them to establish that they distributors had a problem with accounts receivable, and they worked with the legislature. The industry worked with the legislature to have it codified in statute where you can't have past 60 days on the books receivable, or you go to COD. So we are trying to immerse ourselves in exactly what the ABCC is doing, their platforms. We had multiple meetings. We will continue to meet with them. We are very mindful. We've met with folks with $1 million in AR. And how do you operate a business? You get debanked. I mean, how do you operate a business with $1 million in AR?
Right.
So we are very mindful of this. What we were told is that it was the industry that the liquor industry, the alcohol industry, drove this because it was such an issue.
Right.
And they worked with the legislature. So if squeaky wheel gets the grease, I guess.
Yeah.
I'll say. But we are trying to address this issue. We are working on it actively right now.
Appreciate that. And yeah, that's the model that makes me understand that it is possible, is the ABCC's model of AR management. So I do appreciate that. But it is, it's going to continue to erode the industry while that's not in any sort of controls.
Right.
Yeah. Just to add to that, Tim, and I'm glad Commissioner Roy brought up the points about how we are looking at the AR issue. We know it's not just an AR issue in Massachusetts, it's industry wide.
Yeah.
It doesn't shut the door on anybody being able to do business. It just, as Commissioner Roy and we've learned, ABCC put you on that list, and it means that licensees can go in, look at the information, and charge on delivery. I do want to, you pointed out the leadership rating program. We've looked at it. It's been on the books for a while. This past semester, I had students from Northeastern University do a capstone project to look at the effectiveness of similar type programs. I will tell you candidly, and I'm sharing this with my colleagues, I think we ought to go back in and look at the criteria. I think the criteria is a little bit too easy to reach in some of the categories.
Yeah.
But I do agree with you. It's a way to help single out the people that are the good actors.
Right. Well, I plan to submit an application since we'll be the only one applying and see where we get with it. So.
All right.
Thank you. I appreciate it.
I just want to say ditto to your point, Commissioner. That's been something that we need it. We should have it.
You're talking about the leadership?
Yeah.
Yeah. Well, what an amazing way to identify, people who stand out. And again, I mean, I think it could really make a productive relationship between licensees and the commission. So.
Shopping. Where it matters.
Yeah, exactly.
So. No, I want to hear from them.
Yeah.
Better try to hear me.
Thank you. Appreciate it.
Thank you so much.
No applause for me?
All right. Our next,
Everybody needs to get a
our
boss.
next person is Erica McGee. Welcome.
Thank you.
Good morning, Commission. Clearly, I'm dressed for the occasion today, so.
Appreciate it.
What I've been hearing, I'm very encouraged by, and I guess now my question is kind of going to be redundant. And it's simply that medication is covered by insurance. When will patients like myself be allowed to get prescriptions for the medicine that I need and to be covered by Mass Health? Yes, that's my question.
That's not this agency's portfolio or kind of what our regulatory authority is. But
Yes,
your comments are well taken.
yes. Saved by the bell.
I think it works.
Yeah, Erica, thank you for that question. And I actually had this conversation yesterday with our chief of staff.
Okay.
So, Chair Stebbins, when we opened the meeting, talked about a memo, that came from the Department of Public Health, the commissioner, and on the letterhead is the governor, lieutenant governor, secretary, and Commissioner Goldstein. And basically, raising awareness about this medical marijuana program. And this was sent out to physicians, certified nurse practitioners, physician assistants licensed by the Department of Public Health. This is a big first step.
Yeah.
In acknowledging our program, recognizing the benefits of this program. I think this has enormous potential to lift more stigma, if you will. And I had a conversation with our chief of staff yesterday about, and I asked him if he could work with our director of government affairs to reach out to Blue Cross, reach out to some of these insurance companies to have a conversation to make them aware of this memo. I think other states are moving in that direction as well. So, just think of something as like acupuncture. Just a decade or two ago, that wasn't covered by insurance, right? So, if I had a crystal ball, I'd say someday it's gonna be. I can't say it's tomorrow, but I think this memo goes a long way to help get us to where we need to go. And we're gonna do more outreach to insurance providers and other agencies. So I would just say hang in there, and we're trying on our end to bring awareness. Chair Stebbins is right.
Yes.
It's not in our purview, or we don't have the authority to say Medicaid has to cover this. But we are, I think this is a good step. So
Yes,
hopefully that answers your question.
yes. Thank you so much.
Do you have other thoughts or comments that you want to provide during your time besides that one?
Well, yes, I am a patient, like I said, and I am one of those patients that has a limited income. And what brings to mind was last year, I was unable to access my medication. I had both feet in, I wasn't able to walk. I had boots on both my feet. And certainly a dispensary that could do a delivery would have certainly been most helpful to me. But for weeks, I went without my medication because I didn't have any access to it. And I think that's very disconcerting. I also want to add that I am actually an SEP participant as well. And I want to have a delivery business in Western Mass where I live, so that I can be able to fill in, in that gap where there are other patients like myself that, become homebound and can't access medication properly. So yes, yes.
Erica, have you talked with our EPCO team about pursuing a delivery license?
I have, yes, yes. Yes, thank you all very much.
Gillis. Gillis. Mr. Ryan Zachlin. Okay. Megan Clements. Alex Presser. Gary Gill.
My glasses broke on my way over here across the street, trying to cross the street, so I felt kind of lopsided. Good morning, DCC Board. Good morning, Cannabis Control Commission. My name is Gary Gill. I am a medical marijuana patient, and I got a bone to pick with you. I'm upset with your letting the. I'm upset with what I'm letting. What's happening to the medical program. For 31 years, I shared my life with a guy who I was married to legally for 31 years. He passed away of AIDS. His name was Jimmy. For 31 years, we were together. The last 10 years of our relationship and our legally marriage, I became a caregiver. But I didn't become a caregiver just for him. I became a caregiver for my whole community in the North Shore called Salem, Massachusetts, for people that are HIV and AIDS affected. Over the years, I have poured my heart into the North Shore, working with seniors in the LGBT community and officials. I have advocated medical marijuana for a long time. I have helped lots of people get their medical cards. I've walked them through the process, and I've told them it was worth it. And now I see the medical dispensaries closing. But I don't see the Cannabis Control Commission eliminating the barriers that prevent new ones from opening. I don't get it. Why haven't you acted? It's not like it's a new thing. Advocates have been warning about these barriers for a long time, and we really have been from the beginning. You want to talk about medical program? Fine. Let's talk about how backwards it is. The system was built on barriers that don't need to exist. And now you're leaving patients stranded because of these fixed barriers. Do you know who gets hurt when you leave the medical program on autopilot? My seniors, my community. We all are real people, all suffering. Our suffering doesn't wait for you to get around to fixing this. You're holding back our medicine. And let's call it what it is. This is discrimination, somewhat. The lowest people on the totem pole for anything is discrimination. When there's discrimination on a big impact like this, it has a huge effect on a daily basis of somebody trying to get medicine, especially when they don't have a car, they don't have transportation to get to anywhere. They're on a fixed income. They have high rent, and then whatever's left over at the end of the month, maybe they can go out and buy a bag to get them through another month, to take their pills, to eat so they don't have wasting. Wasting is the biggest problem with HIV and AIDS patients. When you smoke marijuana, it gives you an appetite. It gives you a weight. It gives you the ability to eat without throwing up. It gives you the ability to have a long life ahead of you if you're able to make it. In June, I was in the hospital for 19 days with pneumonia. I almost died. But in the process, I kept hearing all this stuff about all the dispensaries closing. In the very beginning, when I was working with the city of Salem, running for city councilor for that town, and I did very well for my very first time. I got on the ballot, but I didn't get my 1,500 votes to get into the office. I know what I'm doing. I've been a spokesperson for HIV and AIDS patients with the Cannabis Control group people in Massachusetts Patient Advocacy Alliance from the very beginning. When I testified many times at the State House, and I did it not only for myself, I did it at that time for my partner who is still alive. Now I'm doing it for a whole community of a whole bunch of people that can't get to dispensaries sometimes. We take it to them sometimes. We help them out every way we can, but it's getting very difficult when all the dispensaries are closing. In the very beginning, each town was supposed to rotate the availability of an application. That fell to the wayside in the very beginning. It was supposed to rotate a recreational, then a medical license, a recreational, then a medical license. None of the towns did that. They took and went for all adult services because of the money, the tax. Well, when it boils down to it, the people on fixed incomes can't afford that. They can't afford a lot, and they're barely living. I'm barely living in the apartment I'm living in at $3,000 a month on a very fixed income. I'm not buying my pot anymore at a dispensary. I'm going to black market, as some people have said. I don't want to. I followed all the rules to get to this part, to get a card. I can't even afford to keep my card now. So you tell me what the real problem is. The problem is greed. When you make the program of the adult industry as easy as it is, and then you take and hurt the people that really help the adult program get into business, it doesn't make any sense. So I really think that you need to take a deep, deep look into the system and just do away with all the barriers. That's all we're asking. Make it easier for a medical dispensary, like that gentleman said back there, $50,000. And when the adult industry can just open up a door and put stuff on the shelf, and they don't have those barriers or those hoops or those hurdles to jump over when it boils down to money. Of course, everybody thinks that pot is the money situation that's going to take care of everything. But if you're blocking the medical program from maybe moving forward, you know, it really serves no purpose at all to have the Cannabis Control Commission at all. Because if it boils down to it, people are still going to go back to black market. And then that's where the real industry is going to go crazy. I think that's all I have to say. And I thank you very much for your time.
there's MTC deserts, for lack of a better term, right? And I think I've heard that from just about everybody so far.
Just remember, I'm only one. Several people that are in my same position
Yeah,
that are not even in this room tonight.
right.
I mean, today,
You're their ambassador. You're their champion today, right?
but there's a lot of the same
Yeah.
story out there that
Yeah.
are having the exact same problem. It could be fixed very easy. And I hope that you all realize that, and you have the power to do it, so. Thank you.
Thank you.
Thank you.
Can we take a 5-minute break? We'll come back as, make it a little bit longer than that. We'll come back in 11.
Thank you. And there's coffee and donuts outside.
If you need a ride. No, I'm not taking the bus.
Yes.
Yeah. Yeah.
Yeah.
All right. All right. Now Megan Dibby. That's right.
All right. Good morning. There's no need for me to introduce myself to everyone up front, but for the public, I'm Megan Dubey. I have just under 5 years of experience in the Massachusetts cannabis regulatory space and previously worked in the regulatory space within health insurance. Beyond my resume, and what I think is the most important, is that I'm a Massachusetts medical marijuana patient who continues to be disappointed with the perpetually shrinking availability of my access to medicine. I suffer from multiple chronic conditions, including anxiety, major depressive disorder, insomnia, and high blood pressure, and have suffered periods of disability over the last year or so when one or more of my conditions has disabled me from being able to work. This has been a huge adjustment, but one that cannabis has helped me survive through without feeling like a zombie and emotionless on benzos. I also recently suffered a traumatic brain injury. Word to the wise, be careful on the ice. This led to testing, which is looking like a possible diagnosis of MS. Getting this information and continuing to go through testing has been scary, and I genuinely think I wouldn't have been able to sleep at night if it weren't for high-dose edibles and locally grown pre-rolls. I also live out in Barrie. For most of the people who don't know where that is, it's about 50 minutes northwest of Worcester. The closest cannabis retailer to me is 15 minutes away, but to get medicine, I need to drive 25 minutes away. And I do not have a market to choose from if I go there, unless I decide to go 35 minutes away, where there's more than one medical option. I tell you all of this to provide you with a picture of somebody who's one of your medical marijuana patients served by the regulations you have the control to change. Yesterday, I emailed a 40-page white paper to all of you commissioners. It is also posted on my LinkedIn, so I'm not going to take time diving through all of it. But the 7 recommendations that I made, which are followed by supporting information, are the following. As everybody's saying, remove vertical integration. I have provided countless support to why this can be done by you as commissioners, and it does not need to wait for a change in the law. Number 2. Remove the requirement for NPs with more than 2 years of experience to have a physician involved in the certification process. This is in line with Massachusetts law, and all of the support for that is also in the paper. Number 3, create an anonymous complaint structure. This is imperative. There needs to be a way for consumers, for people working in the industry, to all report what is going on. People need to be able to report when there's mold that they're working with, and they need to be able to do it anonymously without fear of retaliation, because it has been shown in this industry that retaliation is very, very real. Number 4, certifying healthcare provider education. There's constant talk about health and safety, but yet we don't require our providers to have any education in cannabis. None. We require the people who are working in the lowest paying jobs as bud tenders to have more education in cannabis than the medical providers certifying our patients. That should be unacceptable. There was a fear when the regulations were initially written that there would be not enough providers who would want to take part if they had to also have some sort of continuing ed specific to cannabis. That can't be the reason that we regulate that way. Our patients need to be able to choose from providers who understand the plant, who understand the I'm not even going to try to say the rest of the word. There you go. Of what happens when they either smoke or use an edible, and they're also taking, for instance, a seizure medication or any other kind of medication. There needs to be education and people need to be able to access that. If you're not going to require that the healthcare providers are educated, then the commission has the duty to educate the public. Number 5, create a provider directory. This kind of goes on the last recommendation. The law states that there must be a confidential directory of providers. It does not state that they cannot also opt in to a public provider directory. This has been something that I brought up to the commission countless times, and I think that it's really time to look at that so that people can also understand who the providers are. My most recent and my last year's recertification, my phone call was 2 minutes and 35 seconds and 2 minutes and 55 seconds. That's how long it took me to get certified. Not once was I asked what other medications I'm taking. Not once was I told how maybe I should consider some different kinds of cannabis for anxiety or other kinds that might actually make it worse. There's no education provided. If there was a provider directory where we could see how people are educating themselves on cannabis before we choose that provider, before people who are already struggling with low income pay $100, $150 to see a provider who's giving them 2 minutes. Number 6, the leadership rating program. I'm so excited that other people mentioned this today. This has been in the regulations since 2017. 8 years later, we've done nothing. Let us see who's committed to our communities. Let us see who's treating workers right. Let us see who's hiring within our communities. Use the leadership rating. You have it, make use of it. Recommendation 7, positive impact and diversity plans posting. These documents are muddled within all the other documents of your public meetings. To find a diversity impact plan or a positive impact plan for any of the licensees, you have to go through too much. I can't even tell you how long it took me to find just one. There should be a specific place dedicated on the commission's website for positive impact plans and diversity plans. This will actually take some of this off of your shoulders. It will allow your community to hold these licensees accountable. They are saying that they're going to serve certain communities. They're saying that they're going to do expungement clinics. Our communities should be able to quickly find that information and hold those licensees accountable. In addition to my recommendations in the white paper, I'd also like to pose a recommendation relating to testing, as health and safety of people with using medical marijuana should be especially important. If the commission is concerned about the many issues in testing, then why has no attempt been made to backfill the director of testing role? This is a highly technical area of cannabis regulation that not only requires experts in the scientific field, but also staff that can then use that expertise to improve regulations and guidance documents, as well as to ensure that all commission testing staff are properly and consistently trained. The industry should be especially concerned, considering the administrative order issued December 17th of 2024 without any expertise of a director of testing. The current testing team includes 1 manager and 4 analysts. For agency structure, the testing manager should be reporting to a director. This director is especially important in the investigations and enforcement department, where the chief of investigations and enforcement has about 80 staff that report to her through 7 direct reports. The prior director of testing vacated the role on August 9th of 2024, the same date that the director of licensing role became vacant. The director of licensing role was not only posted, but by September 12th, 2024, it had been filled by an internal candidate who previously served in an enforcement counsel position. I'll close with this. At the start of the meeting, a commissioner said they want to just tear up the medical regs and start over. I implore you, do not do this. These people in this audience have been providing this feedback for years. We are getting closer to 10 years of them providing this feedback and not being listened to than we are from the start of the cannabis industry. They deserve for you to go back and read the testimony that they have given previously. They deserve for you to go back and look at Commissioner Kay Doyle's memo that in 2020 recommended to get rid of verticalization and provided a clear path for that. They deserve for you to look at the DPH memo from 2013, where they acknowledged that this is not a part of law. This is a decision that was made by policymakers to have vertical integration. So with that, I'll leave that with you. Please learn from everybody here. Please look back, not only forward. That's the only way that it's going to get better.
Megan, I just have a comment. Yeah. Thank you. And also, I think I might have been the person who said let's rip up the regs. Was that me? Okay. Thank you for that comment, because I think when I speak, I'm kind of big picture, high level, I'm talking out loud. And we got to be careful what we say at these public meetings, because then people take it to like the next level, right? So thank you for saying that. And thank you for saying, let's look at all these comments. Let's look at past, present, in order to, look at these regs. So thank you, but it also allows me to clarify. So
yeah, and I think that there's a very good example, in practice, that with social consumption, even a lot of where it's landed now is where, if you look back, the conversations were the same 5 years ago, 6 years ago.
So I appreciate it, because I don't want to get too far off, but I just wanted to say that just because we're all here so that nobody has any confusion. But I appreciate your comments. Thank you. And thank you, Commissioner Stubbs.
Thank you. Yeah, Commissioner Rivera.
Thank you, Megan. And I did read your entire white paper. And I did read former Commissioner Doyle's memo on talking about a couple of options. The legislature needs to address the license caps, or we could do endorsement. So I did read through that. Some progress has been made, though, on some of the points that you raised. I just want to kind of go through a few of them. So the remove requirement for NPs and certification. So we did address that. And I believe it transferred over to the medical. So they no longer have to be under a certifying physician as long as they are a certified nurse practitioner. So there's progress there.
They do still need the certification, the sign off of a physician in order to be certified by the commission. It's part of your regulations.
Okay, I misunderstood what you were saying.
Yeah, so it doesn't take away that even if an NP is practicing independently.
I misunderstood what you're saying. Okay. And then the anonymous complaint line, I have been advocating for this since the passing of Lorna. I'm encouraged to hear that there's progress being made on that. I was informed of that. A lot of progress is being made. I have requested respectfully if Chair Stebbins could put it on the March calendar so we could get an update. So there is forward progress on that. And if it kills me, I want to see it come to fruition as well. I think it's critically important.
Yeah, I think there's some low hanging fruit in that too.
Yep. And then the provider directory, I did bring up, maybe a year and a half ago, 2 years ago. And I agree with you. We should have an opt-in for that, and being mindful of the confidential directory. But if it was voluntarily an opt-in, I do support that, because folks, it's up to Google to tell you where to go. So I do support that. The leadership rating program, I know Commissioner Camargo, you have brought that up many times. So I do agree with that. We had mentioned the positive impact plans and diversity plans, and Commissioner Stebbins actually came up with the thought of having folks put it on their website to see the impact. I think we all support that on some level, and that's open for further discussion. So, and then the director of testing role has been filled. I was part of that interview panel. I welcomed him. When do we have a meeting? Tuesday. I was here Monday at headquarters to welcome him, Daniel. It's great news. And so he is up and here, and I was here Monday to greet him, and then I welcomed him on Tuesday's meeting. So I think some of the things we're making progress on them. Some of them have been completed, but obviously there's more work to do. So thank you, Megan. I appreciate it.
You're welcome.
Next up is Billy Flynn.
Points.
Good morning. My name is Bill Flynn. I'm a medical marijuana patient since 1989 through cancer that I had back in the day. I spent a good portion of my life as an activist, the board of director, and the president of the Mass Cannabis Reform. And back in 2016, coming here, even the same questions of asking why all these regulations and fees for medical patients. As iterated by many of the people that spoke and my esteemed colleagues that are here, a lot of these people are on fixed incomes. And to have to pay for a medical card and then not be able to have access for it is borderline insane. You're denying people access to medication that they need. It's about compassion. Where's the compassion here? Take care of these patients. The overregulations, which started way back, still going on to this day. How many times do people have to come here and speak on that, overregulations for medical cannabis? You're failing the patients. I was on the front line here with the patients, right out in front of DPH, saying we need this and we need access, which this industry seems to be riding on the backs of patients, but then turn around and cast them aside. It's not right. It's not what this program was supposed to be about. It's about people. And you got to listen to the people, not the MSO that comes in with the big bucks to tell you, look what I can give you. This was supposed to end the legacy, underground, black market, whatever you want to call it. Those people should have been lifted up and be able to have a business, small business. It's not a new business. Okay, this has been going on for years. People should have been lifted up, been able to have a small business. If I can grow my own and take it to a lab and have it tested and it passes all those tests, I should be able to package it up and I should be able to take care of my friend, my patients, anybody who needs it. Okay? And if it comes to the point where say, hey, regulation for your recreation, I have my number for pay my taxes. It's not hard. It's a business. It's a small business. And it's being taken way out of context here. Like I said, over regulations. Cut some of those down. Shouldn't have to have $500,000 in escrow to take care of patients. You know, or a $500 fee for somebody that works for my company. Come on. What happened to taking care of people, helping people? The compassion is lost here all along. And I'm sorry to say, like I said, I've been away from this for about 6 years. Had my own medical procedures. I've had 5 procedures in 4 years, all with the help of medical marijuana, with my CBDs, multiple different compounds. I did it. It's documented. There's not much more I can say about it. But you have to listen to the people that are actually in the field, okay? It's regulation and commission was all put together by people who really didn't reach out to the cannabis community and talk to them about it. Although, yes, there were a few, but years ago when I came here, when this all started, they were more or less pushed aside. The big money people got their say, and here we are today. Like I said, it wasn't long ago. Saying 10 years, going to be 10 years now, and we're still here. This was brought on by the patients. Everybody said, take care of patients first, right? Patients first. Patients over profits. How's that? Patients over profits. You want recreational? Sorry, you're gonna have to pay the tax. That's okay. You gotta have access to it. But you shouldn't be drowning out the patients who put themselves out there in 2012, marched the streets and said, hey, I need access. Can you help me out? And that's what they need. And here we are today, falling apart. Hey, can you help me out? Again, compassion, patience before profit. That's all I have. Thank you very much.
Sound you kind of hear going off is kind of when we hit the 3-minute mark for folks. But obviously we want to be flexible, but we also want to make sure we get everybody's testimony in today. Terrence Williams.
My
You have
computer converted to a different language, and I don't know how to come back.
all right.
I just move my, I'm turning it off.
Hang on a second. Is Terrence here?
Okay.
Okay. While we're solving a technical issue, is Peter Lynch here? Okay. Ron Gabriel? Okay. Danny Carson, is Danny here? Danny's here. Come on up, Danny. We won't start until Commissioner Roy is back to her spot, not typing in Russian.
No, if you need to say anything, I don't know.
Okay.
Thanks. I can bear with it somehow. Hold up.
Yeah, next week.
Yeah. Maybe shut it down, Commissioner. Try that. Okay, sorry about that.
Danny, and then just so people know, just kind of going down the list, next I have Erica McGee and then Ellen Andrew Kaplan.
Eric.
Oh, I had you on here twice. Never mind. Okay. Then after Ellen Andrew Kaplan will be Janine McKinnon. Okay. Go ahead, David.
Thank you, sir. Hi, my name is Danny Carson. I'm here today to represent workers and consumers and specifically patients. Today, I come back to you with further testing information as I've continued to test products off the shelf in both the medical and the adult use market. I've identified 29 cannabis products that have failed total yeast and mold testing from 9 different cultivators. These products initially passed testing conducted by 5 separate labs, raising serious concerns about the reliability of current testing protocols. Every one of these contaminated products has the potential to reach medical patients, including those who are immunocompromised, putting their health at significant risk. To clarify, the 9 cultivators, Holistic Industries, the Heirloom Collective, INSA, Renew, Resonate, Spark, Happy Valley, Impressed, and Trees Company, and the 5 labs who originally tested them, Kecha Labs, Cambium Analytics, Analytics Labs, Green Analytics, and Steep Hill. Beyond patient safety, we have to consider the more than 20,000 registered agents who handle these mold-contaminated products every day. I have personally spoken with at least one current worker from each one of these facilities where these products have been found to fail. And in every single one of these cases, there is at least one worker currently suffering from respiratory health issues due to the exposure of mold. The issue is not theoretical. It is happening now. And until people are willing to acknowledge the problem for what it is, a solution will remain out of reach, leaving both workers and consumers in danger, just like Lorna was. This medical This medical market depends on strict testing requirements to ensure its safety. Yet at least 5 testing labs have failed to uphold those standards. It is your responsibility to take action. No other entity in this state has the power and authority to do so, but you do. Workers, patients, and consumers are counting on you, and we urge you now to act before more lives are harmed. Thank you.
Thank you, Danny, and thank you for all your advocacy around patient, consumer, and worker health and safety. I too, like my colleagues, take it very seriously. I would respectfully request, could you email us your testimony today as well?
Yes, ma'am.
I'd appreciate that. I've spoken about this many times publicly, whether it's lab shopping or contaminants passing when they shouldn't, or potency inflation, this is a nationwide problem. It's not unique to Massachusetts. I am diligently focused on this. We have made some progress, removing a la carte, so they can't shop around for labs in that way. I am committed to seeing this tip line come through, and I know you're working on legislation to help provide folks with anonymity with Rep Whips, and she's a great champion to help do that. I hope that comes to fruition. But standardization, standards lab, open data to help keep this an honest and healthy industry is essential. So I am committed to hopefully seeing all of these through. We have a new director of testing, who I said earlier. Wait. I think she's done. Okay. Danny, we have a new director of testing. There's a lot of opportunity here to get us to a place where we all feel confident in the accuracy and labeling and the safety of our workers. So I'm committed to that, and I know you are, and I know my colleagues are. So we are making some progress, and I wish I had a magic wand and I could fix it all today. But we don't have that, but we are working on it diligently.
Yes.
So thank you.
Thank you.
Ellen Andrew Casper. Then next up is Janine McKinnon, and then Julian Duplan. Hopefully I got that right.
So my name is Ellen Andrew Casper, or Ellen Casper.
Just pull the microphone a little bit.
And I'm probably going to echo many of the previous points, but I'm coming from a medical marijuana dispensary. I'm an RN and a veteran, and I've been involved in assisting to start up and do outreach for a small locally owned and operated medical dispensary that opened in 2017. We were among the early medical dispensaries that helped to safely and compliantly usher cannabis into Massachusetts, and we've witnessed many changes in the industry since. A recent article in MJ Business stated that the total number of MMJ patients decreases by roughly 1/3 after rec sales are launched in states. It certainly seems to have been the case here in Massachusetts. We are very committed to serving medical patients, but with a plethora of AU dispensaries and the flood of cannabis on the market, it's difficult to compete with a med license alone. We've been forced to spend time and money to campaign in 2 towns to overturn rec cannabis bans so we could add AU sales in order to continue to serve our patients. There's much publicity around the number of med dispensaries closing, resulting in decreased patient access to tax-free medicine and other patient benefits. A closed medical dispensary not only impacts patients, but the livelihoods of dedicated employees, many with families to support. A proposed remedy for this lack of med dispensaries has focused on eliminating the vertical integration requirement for a medical license. The idea for vertical integration was to get product out and provide patients and dispensary staff assurance of its known quality. We sell almost exclusively our own products and can speak to and educate about them. Sourcing third-party products for medical essentially erases that product distinction. Being involved in opening a small medical dispensary required to invest millions of dollars to vertically integrate, along with the added monthly operating costs for staff, scrubs, PPE, HVAC, electricity, water, plant food, etc. It doesn't seem quite fair to allow a much less expensive path to a medical license. Rather than watching dispensaries close and fighting to offer easier access to med licenses, a quicker fix for improving patient access now would be to support existing medical dispensaries that offer delivery services, are operating compliantly and honestly, and are committed to supplying safe, quality cannabis to patients. Some suggestions. I know everyone's reported that it's a $50,000 fee for medical every year, but I also want to be clear that we have a very small retail-only dispensary that also is charged $50,000 a year. It's not vertically integrated. It's just like a small little store. And it is crazy. And adult use licenses are $10,000 a year. If vertical integration is eliminated, all the individual licenses that we would have to get would come to $27,500 as opposed to $50,000. So for the 6 years that we've been in business vertically integrated, it would be lovely to get $20,000 a year reimbursement for that, and $40,000 a year for the 3 years that we have been paying $50,000 for our small retail store. Consider having one license only, and consumers can decide whether to access AU or medical within that facility. The automatic ability to add adult use to a medical facility were available, expediting that, and with fee reductions for compliant companies in business for years. We've had a very, very difficult time. I mean, we've been in business, we're super compliant, and we've gone through the application process, we've done it for years, and yet we still have such a difficult time every year renewing our license. Decrease the cost of employee registrations. That's a problem. $500 per employee. We have 60 employees, and people come and go kind of quickly sometimes, and we'll pay for someone, and for some reason they don't come back. So we have a year of paying for that person. We have separate badges for each one of our licenses. So our president, if we ever get adult use open in Hull, he will have 4 different badges, and that's crazy. Not only, the plastic itself, but consider employees owning badges rather than companies. The dispensaries, we all train our staff, and we feel that the RVT training requirement isn't necessary because, we're responsible for training our staff. We've had an instance where fingerprints that we've already submitted are being required again, and it holds up a licensing process when you already have fingerprints on people, and I don't think they changed. The reciprocity for medical patients with other states, ensuring compliance with the use of sales, promotions, loyalty programs intended to benefit patients going to medical dispensaries and not for use in recreational dispensaries. License caps for areas that are already saturated. and ensuring public safety with honest testing and potency labeling. As a compliant company with patient safety in mind, it's very expensive to maintain a clean facility and impossible to compete with companies putting out contaminated, falsely labeled products. Recall contaminated products and remediated products. It should say on a label if someone remediates a product, because we don't. Thank you very much for this opportunity and for all the work that you do.
Wait, Alan. Thank you for your testimony, Ellen, and I have had the opportunity to visit your facility, and you gave me a tour, and I was very impressed by what I saw that day. So thank you for that. I just want to understand what you're saying. So with the $50,000 annual fee, you're saying basically unpack it and like break it apart.
Yes, so if vertical integration is gone, then we were thinking that we would need to have a manufacturing license. We would have to have a production license. We would have separate licenses, and for Hull, we would have just a retail only license, which would be the 10,000. So for all these years, if you just say, okay, you can go ahead and open.
So if eventually there is no vertical integration, then you're saying for consistency, then the product manufacturing would pay its own fee, the retail, it's.
Well, we were just comparing the cost of what we've been paying as opposed to if we were going to separate the vertical integration.
Right.
And we would be manufacturing and we would be retail. We would have all those separate licenses.
That's right. That's what, yeah.
Yeah, that's what it would cost for it. And so feel like, we understand it's super important, for patients to have access, but we feel like there's things that can happen like quickly to support us, Yeah.
I'm off that.
Ellen, just to add, obviously, it's not just the medical program issue, but the badging of employees. We've talked about that.
Yes.
I personally think it's
Yeah.
ridiculous. One employer, and I got 3 laminations hanging around my neck.
Yeah.
So we are going to work on that
Yeah.
also. That obviously would just not impact the medical industry, but the entire industry. But
Absolutely.
bringing that up.
Alrighty, thank you so much.
Janine McKinnon.
I just have a comment before. Okay, before. Oh, no, I'll do it after. Okay. Go.
Hello, my name is Janine McKinnon. I'm here with both of my sons, Zachary and Jeremiah. I'm a 54-year-old mother of 4, a medical marijuana patient. This is my son, Zachary, my firstborn. He's 32 years old, autistic, and has epilepsy. He is nonverbal and as his legal guardian, I speak for him because he cannot. For years, Zach's lived in a group home. This January, I made the decision to bring him back home. I had no choice. He was mistreated, over-medicated, injured with no explanation, so severely that he was hospitalized for brain bleeds that were hidden from me. The group home has also refused to give him medical marijuana. Now that he is home, I can make sure he has access to his medicine. I rely on medical marijuana too. Growing up, I was surrounded by a lot of dysfunction. This trauma left me with PTSD that follows me to this day. I also have fibromyalgia and Crohn's disease. Cannabis is my medicine, and the same is true for Zachary. I got my medical marijuana card 10 years ago. Now I'm sick to my stomach worrying about what's happening to the medical marijuana program. It's getting harder and harder to access the medical program, but there are dispensaries everywhere. So why can't patients go get their medicine? The answer is simple, the vertical integration requirement. Only dispensaries that grow their own cannabis can serve medical patients while others are locked out. For years, we've been told this requirement is hurting access, and you've ignored us. Spent more time talking about lottery tickets inside dispensaries than real solutions. And lately, you've started saying vertical integration out loud, but words mean nothing without action. And still nothing has changed. Meanwhile, patients are left wondering if their medical program will even survive. Patients shouldn't have to keep proving why these barriers are unnecessary. You should be the ones explaining why you've kept them in place. Because let's be real, Making medical dispensaries grow their own plants is a completely unnecessary rule. There are dispensaries open today that are ready and willing to help us, but you won't let them. Instead, you force us to struggle because of an old rule. Just because something has always been done a certain way doesn't mean it should always continue that way forever. It's clear to anyone looking at this vertical integration requirement isn't protecting us. It isn't helping us, it's hurting us. You have the power to fix this. Stop the vertical integration. No more barriers. Let every dispensary serve medical patients, and do it now for me, for Zachary, for all the patients in Massachusetts. Thank you.
Thank you. McKenna, I just want a quick comment. When I first met Jeremiah, I had a conversation with him and I'm like, tell me about yourself. How did you get to where you're at? Tell me a little bit about your family, your work. But I just want to say, congrats on you as a mom in raising such a great young man. And he does a lot of work. He's a great advocate. Yes, exactly. So it's the first time I meet Zachary. So I just want to say thank you because it's nice to meet you in person.
Thank
So
you.
yeah, thank you. And thank you for testifying today.
Thank you so much. Thank you. Thank you.
Commissioner Roy, do you have a All right, we have three more in person. Again, Julian DeBelle Duplan. No? All right.
Is there?
Oh. Sorry about that, Julian. I didn't see you around that. Go ahead.
First off, thank you to the Cannabis Control Commission for having this session today. I think it's very important, and I'm grateful that we're focusing on the medical program. Just to introduce myself, my name is Julian DeBelle Duplan. I'm one of the owners of Easy MedCard. We've been certifying patients and working with providers in this program since 2022. Although it's only been a few years, we have noticed some changes in the program, really when it relates to the access for patients to be able to shop for their medicine. And I'm probably going to echo a lot of what it's already been said in this room. And I also just want to highlight that the collaboration here today is awesome and wonderful to see because I think it's needed. We've heard from patients, we've heard from clinics, caregivers, the MPAA, and licensed operators as well. So I just want to say thank you to everyone that has participated and spent time. I guess some of the things I'd like to highlight really is medical cannabis is essential healthcare. During the COVID pandemic, MTCs were allowed to stay open while adult use retailers were closed. And obviously there is a purpose to that because it is essential healthcare. And I think all the remarks today are basically showing us that it matters and it is necessary for lots of residents in the state. And I think there's some positive things and work that we can do in the future to really make it essential again and really bring it back to focus. One of the biggest, obviously, and barriers to entry is the vertical requirement. From an operational standpoint, it's extremely expensive. And when you look at the market today, there's over 400 retailers that really I would look at as a resource that could be utilized to serve patients. If you drive throughout the state, which I do very often, you can go 20 or 30 miles without seeing a medical retailer or even being close to one, but you're going to see plenty of adult use retailers. So I'd like to look at them as really a resource potentially to alleviate some of these access problems. And, those are really my remarks. And then I'd also like to touch on Megan's points when it relates to providers in the program. And the directory, I think, is a phenomenal idea. I just want to give you an example of a good one that I've seen in other programs that we actually operate in. And that one would be the Kentucky Medical Marijuana Program. It is brand new, but I'd be happy to show you their practitioner portal and essentially the registry that they have. It's very great. You basically type in a zip code and it pulls all the certifying providers in your area. So I think that'd be a great resource for patients in this state as well. And then as it relates to practitioner education, I do want to echo, I do think that is important. There are plenty of providers in this field that didn't go to school for cannabis, right? It's new, it wasn't an option, and there are actually some great resources out there, and there's actually official continuing education courses that can be done online and would greatly educate some of the providers in the program. And that's really it.
Commissioner Roy?
Yeah, thank you, Julian, for your testimony. And if you would email to us that Kentucky portal,
Yeah.
I would like to take a look at that.
Absolutely.
And I meant to address this when Megan spoke as well. It's my understanding that all certifying healthcare providers must complete a minimum of 2 hours of Category 1 continuing professional development credits prior to issuing certifications for the medical use of marijuana program. So there is some.
Yep.
I don't want folks to think there's none.
Of course.
Whether we can re-examine that.
Yeah.
That's open definitely for discussion.
Absolutely. And, I think my point is more towards maybe just continuing it. Obviously, you need to do it to basically pass the prerequisite to certify, but maybe an ongoing education or a requirement that's done yearly, just to educate the providers as much as possible.
Thank you.
Okay. Jillian, thank you. Oh,
Just a comment.
Yep.
Thank you. Because when we were planning this, we wanted to make sure that it was a diverse group of folks in the industry, and you showing up today with your expertise in the background and some of your experience is really helpful to the conversation. So I'm glad, like you said earlier, the collaboration in the room and everybody who's here. So thank you for taking the time for putting that together, mailing it to us, or emailing it to us. I'm sorry, but just want to say thank you so much. It means a lot. So thank you to everybody, but it's nice to see, folks from.
Absolutely.
So
Thank you for having us.
Yeah, for sure.
Thank you, Jillian. Lucas, there, come on up.
Oh, that's okay.
Hi, guys. Thank you for hosting a hearing, topic-specific hearing. As I've mentioned a few times, I think it's been a few years since the last time we've had a general, not topic-specific listening session. So we really need one of those, just a catch-all listening session where the community comes together and gives you guys our ideas on what should be done to change the industry as a general, not a specific. And I'll try to stay focused on specific, but I really want to mention the memo that y'all let out a couple of days ago to extend the HCA requirements, extend the HCA extension again. So this is our second extension, but essentially a fourth extension. You get 120 days 3 times, and then another 240 days, coming to a total of 600 days. So please extend that again after the 600 days that we already have for another 365 days after that, because this HCA situation is really bogus. The towns are trying to extort from the operators, and you guys see that. That's why you did the 240-day extension you voted for 2 days ago. But the 240 is still just a drop in the bucket. We need to essentially abolish the HCA entirely, so please do that. Medical. H4409 is the deverticalization that Jeremiah and others have mentioned. I think in general, the commission should be talking to the legislature and asking the legislature to do things, because a lot of the things that we keep asking you guys to do, the answer is, sorry, we can't. This guy over here, this lovely lawyer you have, is going to say, sorry, you can't because CMR 500 says you can't. CMR 500 is written by prohibition. It's 8 years ago, 10 years ago, needs to be changed in a big way. So when you're talking about ripping up regulations, I agree, and we need to rip them up in Boston, not here. We need to go to Boston and talk to the state legislature. We need to tell you guys, and then you guys go to Boston and say, hey, legislature, CMR 500, rip it up and rewrite it. So we need, I would like to see the commission do more of that, talking to the state legislature on our behalf, talking to the federal legislature on our behalf to change policies for the better. H4409 is one that would deverticalize, remove the vertical integration requirement for medical operators, and would also take away the $500,000 capital requirement. So they wouldn't have to have that $500,000 in the bank, and they wouldn't have to be vertically integrated. Someone could have a cultivation license or a manufacturing license or a retail license, but not be required to have all 3. I think that's what everyone asked you guys to do today. S1082 in the state legislature would allow for reciprocity. That would allow for patients from out of state to come into Massachusetts, shop in the medical stores. But more importantly, that would allow for patients from out of state to come into Massachusetts, shop in the medical stores, buy 9 ounces of weed, walk down the street and get talked to by a cop and not worry about whether that cop was going to find their 9 ounces of weed, because a patient should be able to have 9 ounces of weed, so says us. But a patient from out of state cannot have 9 ounces of weed in their pocket walking down the street. They can only have 1 ounce of weed in their pocket walking down the street. So they are at risk for arrest by a police officer because they are a patient with their patient amount of medicine. If S1082 were to pass, that would allow, sorry, I'm going to go over because other people did. If S1082 were to pass, that would allow for those patients to have their medical amount of medicine and to buy them in the stores in Massachusetts. It would allow for the stores in Massachusetts to sell to more people. We have college students and tourists and regular people coming in from out of state to Massachusetts because we have a beautiful state and we should be able to serve them as patients if they are patients in their home states. We need to get rid of a lot of the hurdles for opening up a medical store. I think it's been said almost every time someone came up here. There needs to be just in the portal a way for an adult use store to click a button and go over to the medical side, to be able to serve medical patients, to become co-located facility, serve medical patients medicine, that's what it is medicine. If it gets handed to a medical patient, it is medicine, and those patients shouldn't have to pay the 20% sales tax. If y'all want to do a social equity exclusivity period for 3 to 5 years for that rollover, I wouldn't be opposed. So let's say all of the social equity operators that are currently adult use dispensaries for the next 3 to 5 years could click a button in their portal to roll over to be medical co-located as well. And then after that 3 to 5 year exclusivity period, open it up to general applicants as well. A general applicant adult use store after 3 to 5 years could do the same thing I'm describing. A lot of this is asking for the legislature to do more things. So really, let's go to the legislature more as a commission and fight for us, because I mean, we're the little guy, and when we go to Capitol Hill and ask for stuff, it's kind of crazy. They treat us like we're crazy cannabis people, but they don't treat you guys like you're crazy cannabis people. If you listen to us and our wishes and ask them for action at their level, I'll yield the rest of my time. Thank you, guys.
Michael, what?
Comment.
Yeah, go ahead.
Lucas.
Yes.
I just want to say, no one is crazy cannabis people.
Thank you. I appreciate it.
And I had to just throw in a little joke because, you know, it is a lot of work to advocate also within these positions, right? And it's the work that we do. And I was just talking to Debbie that we should give you an award of the best attendance at all these meetings, right? Perfect attendance at these, you know. But I
might have missed one.
You might have missed one, but you know, one or two.
We're in 2 different places.
Yeah, but you know, I think you're leading the attendance, but it's important. But also, like, I know Commissioner Stebbins and Commissioner Roy have been working on a new legislative process, or I don't strategy. I want to make sure I say the right thing, because exactly of what you're talking about. You know, we feel, I want to speak for myself as one commissioner, sometimes we are tied in terms of the language in the regs and the statute and everything else. So I just want to, you know that, you're here all the time, you talk to us all the time, but I just want to make sure you know that. I just want to say thank you again, so.
Thank you, I appreciate it.
Yeah.
Yeah, I would just add to that, you know, talking about our need to improve our relationships with folks on the Hill. I was very happy to see that both Chair Donahue and Chair Gomez got reappointed to the cannabis policy seats. So it's people that we've worked with over the last 2 years. You always run the risk of every 2 years could be somebody else.
Yes.
But in my conversations with them, I know that they're, you know, folk, I think they kind of asked to stay around because I think there is work that both of them see that they want to complete. So it's good to have that news come out of the organizing meeting yesterday.
Yeah.
So.
Thank you.
So in regards to that and the legislature, that's all the stuff that all of us used to do at the State House.
Right.
They listen to us, but now you have the control. You're in the driver's seat. And the fact that you're in that control and in that driver's seat, you can tell them, Mr. Attorney, that this is what you want to move forward. You tell that to the legislature, they will write it up that way. there won't be a lapse in days of waiting once you deliver what your idea is and tell them to enforce it. They're listening. They are their state house, but they are there to listen to you and to listen to us. They listened to us for a long, long time to get to this beautiful place where we're at right now in Worcester.
Thank you.
So, you know, you have more power than what you really think. And if you tell them this is what we need to move things forward, they're going to accommodate you much more, much faster than they would the general public. But they know
Well taken.
we're in if we're in the back seat pushing you, it's gotta be all the right stuff, or we wouldn't lead you in the wrong direction.
Point well taken, Gary.
Thank you.
Thank you.
Thank you.
Michael Vilkans? Michael, welcome.
Hey, how you doing? I'm Michael Vilkins. I've been a medical marijuana patient with the state of Massachusetts since the beginning, I think in 2012. I was part of the Cannabis Caregivers Coalition. That was a failed thing that went down. And recently, I got my card like renewed again, and I went to the dispensary, I purchased some things, and then later that day, I saw a Reddit post of a bunch of mold contamination at the dispensary that I was going to. And then I reached out and I called you guys and I spoke to you guys on the phone for around 45 minutes. And you guys like told me that everything was fine, that everything that was coming out of the dispensaries was safe. And then a few days later on the news, I saw that it was not safe. So it was very odd that you guys were telling me that it was perfectly safe. And then a few days later, instead of like contacting me as a patient of the state, you guys then are talking to the news and all this other stuff comes out. So it's concerning to me that it doesn't seem like you guys are regulating any of the testing sites. I've spoken to them, and I know that MCR is now suing a bunch of these testing facilities, which is a concern to me because if a dispensary can just shop around until they get the best, like to the result that they need, like, how is that beneficial to a medical marijuana patient that could be immunocompromised or have cancer or, you know, something, it could make them really sick and it could kill them. And then you guys just aren't talking to the patients that are asking these questions. And then I don't know what type of go shopping you guys do to go in, but a previous person came up here and had at least 23 samples of stuff that had mold in it. So I'm just wondering what you guys are doing like going forward with like taking these contaminated products off the shelves. And then also with the remediated weed, why did you guys take off that thing? Like I have to request the COA for me to figure out if the weed was manipulated. And like as a medical patient, I don't want that. I don't want to have to look for that. And I had no idea that the medical dispensaries are going downhill. Like there's where I live in Western Massachusetts, there's a lot of dispensaries. And the ones that I go to, they're all medical. I just because I don't know why, but I just think it's a real concern that if I'm going to these stores, I should be having safe access to medication. And then also, I shouldn't have to renew my medical marijuana card every year with you guys. It makes no sense. And I should be able to go to my doctor, and my doctor should write a thing that says I should have medical marijuana, and then you guys should take that and then give me a card. And the card should last until my doctor deems it not necessary for me. And the fees and regulations regarding this. And also a previous person was talking about how the doctors don't really care. Like I'll call up a med doctor, I'll be on the phone for 2 minutes to get my renewal. And that's how it's always been. It's always been like that. Since 2012, when I first got my thing, they didn't care about anything that was wrong with me. They just want the money and they want to give you the card. And then I have to pay the state. So I have to pay an independent person and I have to pay the state. When I'm on Mass Health, I can go to my regular doctor and they should be able to transfer it over to you guys. It's been this way since 2012 and I don't see how it's benefiting people that are, you know, have financial issues at all. And that's it. Thank you.
Commissioner Roy, go ahead.
Thank you, Michael, for your testimony. And I agree, no patient should ever have to wonder of the safety, and accuracy and labeling of the safety of their product. As far as COAs, I believe every patient and consumer should have access to a certificate of analysis, and it's not that way. We recently announced that Massachusetts, the seed to sale system is called Metric that all the licensees have to use. So there is something called Metric Retail ID where the independent testing labs can upload the COA. So at some point, sooner rather than later, this board needs to have a full discussion on how we make these COAs more accessible to patients and consumers. And I do believe if it should be in the COA if a product is better rated in the COA, so patients would know that. And as far as that consumer and patient advisory that went out, I'm sorry that you weren't notified. I did ask our team if it was going to patients. I did make that request. We're looking into that capability for the future. I did that day it happened. I asked is this going out to patients? And it needs to. So we need to work on that. But I know our enforcement and investigations enforcement team are focused like a laser beam on the issues that you've raised, and we are working on them. And, so thank you. I appreciate your candor and I agree with a lot of your points. So thank you.
Thank you.
Thank you, Michael. I have one last person who signed up for in-person testimony, Marco Troiani.
All right. Hello, commissioners. Thank you for taking the time to listen to my testimony. I don't know if you guys remember me, but Marco Troiani from Digamma Consulting. We've set up 49 cannabis testing labs since 2011, starting back in California, though Boston is my home state. So just in interest of brevity, I'm going to read from a prepared statement. So today the commission is taking public comments on the medical program as has been frequently cited in public discourse in Massachusetts press recently. Contamination issues in Massachusetts cannabis is a major issue of concern. Although recreational users are affected by mold contamination as well, medical patients are uniquely vulnerable to contamination of their medicine due to complications such as weakened or compromised immune systems. As a result of this, our organization has submitted to the commission a series of technical documents outlining a practical solution to mold and other contamination by focusing on laboratory data accuracy. These documents are quite dense, but we wanted to share them with the commission and get them on the public record. These documents help outline a very detailed approach to qualifying laboratory data for fraud and inaccuracy. This ability is at the center of many pain points in the Massachusetts cannabis industry, many of which flow from unreliable laboratory data. Through a process of codifying laboratory data quality control requirements and performing forensic audits on these laboratories, the public may see clearly from these reports which laboratory data can be trusted to be reasonably accurate and which laboratory data cannot. This is critical to stopping THC inflation, mold underreporting, or any other form of laboratory fraud or error in reporting. Although we have in the past advocated a state-owned reference lab to aid in the process of determining the accuracy of laboratory data, the documents we have submitted to today's meetings do not require such an investment by the Commonwealth to begin combating laboratory fraud in Massachusetts. Thank you.
Can you obviously submit your comments?
I sent them in email yesterday before the 4 p.m. deadline. I'd be happy to resubmit them before the 5 p.m. one today as well, if that's helpful.
Okay, yeah, I'd like to read them. Thank you.
Thank you.
Thank you so much. Thank you.
Commissioners, it is just about 1 o'clock. I'm happy to take a quick shuttle lunch break and then we can come back and dive into virtual, or do you want to keep going?
Going in person. Wait, say that again.
That's everybody who has signed up in person.
We have virtual people?
We have virtual.
How many? Yeah, I need a break.
23.
Oh, yeah, we can take a break.
Is there anybody else here in person who would like to come up and offer testimony? Okay.
I do have a follow-up question though. in regards to this item was just up there.
Sure.
Are there is there any things set in place right now for dispensaries that have been found to have carried mold and still selling it? Is there any repercussion in regards to those dispensaries with that issue? Yeah. It is a big issue a lot lately. Are they being held responsible for the situations that are occurring as far as mold?
The dispensaries
Yes.
that have product frozen recall.
Yeah.
So if there's an ongoing investigation, we're not privy to the details because in addition to being regulators, we're also adjudicators. So if there was a significant issue, a threat to public health, safety, and we had to suspend, revoke a license, we have to be unbiased when we do that. So we don't have the details of ongoing investigation. What I can tell you, what's been shared publicly, we've had stipulated agreements. For folks that have been fined pretty significantly for instances of mold, and those are public documents. We have discussed them publicly. We voted to ratify those stipulated agreements. So yes, we are holding people accountable. What's ongoing now, we don't have, we're not privy to that information because we have to stay unbiased. So hopefully that answers your question. But when things are ripe, they do come before us.
Do they keep reoccurring? Because in the process, I heard the dispensary that I go to. And when I was in the hospital in June, they checked me out for everything. Come to find out, it could have been the pot that I was smoking. And I almost died. And my doctors told me that was probably it.
Did they document that? Did you report that?
No, I didn't.
Okay.
We can
But
overcome
I
this.
have heard that story from several other people. And the same dispensaries are the same. INSA, Happy Valley.
Sorry to interrupt. I'm so sorry to interrupt. But I just want a point of clarification here or point of order for a second. I hear you. We thank you. But just to respect the public hearing in terms of the conversation that's happening,
Yeah.
I would just ask for a point of order, Chairman, so that we can bring this offline.
And this is why we need a tip line.
Yeah.
We will.
Anonymous, not an anonymous.
It's 1 o'clock. I'm going to suggest half hour for everybody. All right, we'll reconvene at 1:30 and we will get into the folks who signed up to testify virtually.
Thank you.
First time.
All right, we're good? Yep. Okay. Welcome back to this public listening session. We'll now turn to the folks who have been very patient but have signed up to participate virtually. Again, just a reminder, some rules of conduct for the listening session. Try to keep your testimony to 3 minutes. You obviously, if your remarks are longer, you're more than welcome to submit those to the commission. Please use respectful language. And again, any additional comments you want to submit, try to submit them by close of business today. I will turn to our lineup of people who have signed up to offer testimony virtually. Again, similar to folks who are here in person, we do invite any public or elected officials to participate first. We do have somebody, I understand, participating. It was a local elected official, and I believe that is Stephen Mandili. Okay. Our first person to testify this afternoon is Stephen Mandili, a selectman from the town of Uxbridge. Here you are. Hey, Stephen, good afternoon.
Stephen. Hello, good afternoon. Thank you to all the members of the commission and everyone in attendance today for your time. I'm back again. I really wanted to thank the commission for their support of legislation last year to assist veterans to become patients in the medical program here in Massachusetts. We made it further than ever in this last legislative session, made it all the way to the end. We just didn't make it to the floor for a vote. But the bill has already been refiled. It has a new number so far. As today, it stands at, it is House docket, so HD 3064. The language is the same. We had nothing but support of this bill from legislators last year, and we're hoping to get this bill amended and put onto an omnibus bill to help it get through instead of waiting the full 2 years for this session. Your letter of support last year was extremely helpful. I would ask for a similar letter of support for veteran bills this year in regards to medical cannabis. And again, just thank you to your commitment to hearing from veterans and trying your best to make it a space for veteran representations. And that is all I have. So thank you very much.
Stephen, thank you. Just hold on a second in case any of my colleagues have questions. Commissioner Roy, I know you've worked a lot on the veteran issues, so feel free.
Thank you. Share with you as well. Thank you. Thank you, Stephen, for your testimony. And I just want to be clear what you're requesting of us. So in light of the new bill being filed with the same language, are you asking for pretty much the same letter of support around that bill? Or you're asking us to support different, like, we can't support a bill, let me just say that, but we can support a concept, which is veterans access. So are you asking us to kind of like double down and reaffirm our support of veterans access? Are you asking us for different concept, different bill? Like,
thank you. To reaffirm, so where nothing in the bill, if no language has changed, I think the same letter you sent again, because it can't be specific to a bill, but to the end of a bill. So, you know, the desired outcome to have more veteran access. So it wouldn't even need to change.
same language?
Date.
Just change the date. Okay.
Yep.
Okay. Director of Government Affairs and Policy, Matt, just duly noted, if we can work on that. Thank you.
Thank you.
Thanks, Stephen. Appreciate it.
Thank you,
Thanks.
Stephen. Nice seeing you.
All right. I'm going to look to Jessica in the back of the room. She'll tell me when people are ready to go. On my list, I have Joanna Varner. Okay. I know Ellen Brown has to be here. Ellen Brown from Green Path Training, one of our CAB members as well, and a veteran.
Sure, if you guys can hear me.
We can hear you and see you. Hi, Ellen.
Hi, Commissioner Stebbins. Thank you so much, Chair Stebbins. I really appreciate your time. Thank you, Chair Roy. Thank you, Chair Carmargo. I really appreciate all your time. Thank you to everyone here at the commission. Thank you to everybody at the state level, all the subcommittees, everyone that has worked so hard, and everyone that's given testimony today. I've been taking notes, and I'm so excited for our next research subcommittee meeting. I know that there's a lot of work on every level, from the state level, the commission level, the subcommittees level, and it's so great to get to hear all this feedback. I know that you've heard a lot of the points that I wanted to discuss earlier, so I'm going to give you a brief synopsis so that way you can have more time for other testimonies that might talk on new topics, and I'll definitely elaborate in an email. I think that we can all agree there is a need to decrease barriers to entry as it relates to access for licensees. This includes doing things like lowering costs for licensing fees. This includes deverticalization. We also want to increase access for our medical patients, not just those that live here in the Commonwealth, but those that are going to be visiting the Commonwealth. We have some of the best hospitals within the United States, and those that are coming to get care here from our hospitals should be able to get the cannabis they need from our Cannabis Control Commission, tax-free, and with all the different marijuana-infused products that they could possibly need for their care. And this includes things like transdermal patches, suppositories, things that the adult use market just would not have. And we can do for our patients, what we can do for our patients is we can evaluate the entire patient registration process. Commissioner Camargo, I cheered when you said rip up the regulations, because I brought and I knew what you meant when you said it. I brought a good pen, and I'm here and I'm ready to work. We're not throwing the baby out with the bathwater. We're looking to see what we can do, what we can change. And I tell you what, I'd give anything for Proposition 215 and SB 420, back when it was paragraphs of regulations. What we've done is over-regulate to the point of detriment, and that's why it's so important to get rid of what doesn't work and then keep what does. So I BYO'd my own red pen. I'll bring some for everybody else, and I know we're all ready to get to work. So with that in mind, medical reciprocity, we've been a decade in the making, and I really feel like this is the year. I'm so grateful for all the commission support. 194th session, we're going to do a lot of great work. I know that Stephen Mandilli just spoke about the veteran bill. The leadership rating program for MTC has already been discussed. I know it's in the works on the commission side, or at least, something the commission is aware of and working toward. And last but not least, the one thing I wanted to mention that I don't think I heard mentioned by anybody else was we want to make sure that we are adding protections for our patients. We're being mindful of our patients. We want to make sure that in adding protections, we're not taking protections away. So I would really like to see a removal of the hardship cultivation registration before it ever goes into effect. I feel like that will be to the detriment of the Commonwealth. It'll be to the detriment of the patients. So I just really wanted to find a way to redline that before it goes into effect, and I'm looking forward to following up in an email with more suggestions and ways that we can implement some of the changes that have been discussed today. It was great to hear from patients, it was great to hear from clinicians, and I appreciate all of your time and work for the medical program. So I thank you very much, and I'll follow up in an email.
Thank you, Ellen. Any questions for Ellen? Yeah, Commissioner Margo.
Ellen, thank you so much. Thank you for all your work. I'm really excited to hear. You and I haven't checked in a while, so I just appreciate it. But also thank you for clarifying what I meant by what I said, because I got to be careful what I say at public meeting, because our staff will then say, "Oh my goodness, we're gonna, throw away the regs and start over." But yeah, we got to sit there, we got to redline it, and just think about what works now, right? And what didn't work in the past. So thank you so much for your time and your comments and the work that you do as well. So thank you.
Thank you very much, Commissioner Camargo. I really appreciate that. Thank you so much, Chair Stebbins. Thank you so much, Commissioner Roy. It's always a pleasure. And I hope you all have a wonderful day.
Thank you, Ellen.
Nice to see you.
Nice to see you, Ellen.
All right, next. You okay? Next up is Emily Waxman.
Here.
Hi, Emily, how are you?
How are you?
Great.
Hey,
Go ahead.
good afternoon. My name is Emily Waxman, and I'm the Director of Community Outreach at Medwell Health and Wellness Centers. I have had the privilege of holding this position for the past 10 years, and I have assisted thousands of patients gain access to the Massachusetts medical program. Throughout my time at Medwell, I have seen how cannabis has significantly improved people's lives. I am constantly amazed as I watch people who were weak and riddled with pain transform into different human beings. The pain and suffering that once plagued them has dissipated, and they can once again take part in life. As I see this incredible transformation with our patients, I am also watching the premature death of our medical dispensaries. What was initially a promising system designed with patient support and care in mind has completely diminished. Presently in Massachusetts, there are around 350 recreational dispensaries and only 92 medical. These numbers are staggering and as a result are directly impacting the lives of many. Medical cannabis should not be looked upon as a luxury. It's a lifeline for thousands of patients suffering from chronic pain, cancer, and other debilitating conditions. Yet, as we see more medical dispensaries closing or converting to recreational sales, patients are left struggling with fewer options. Recently, I was at an educational event where I met a longtime patient named Judy. Judy explained that she has multiple recreational dispensaries around her, but continues to take a 35-minute car ride to the nearest medical dispensary. She refuses to give up her medical card. She cannot afford the taxes and needs to be able to have her 10-ounce allotment to treat all of her ailments. How can this be acceptable? This cannot possibly be what the state intended when the rules and regulations were originally created. We must prioritize patient care by expanding the access of medical dispensaries, not reducing it. Patients in Mass do not deserve, nor should they accept, the increasing lack of access to their specialized products, tax benefits, and other discounts that they have been used to receiving. Without these options, patients may need to consider less effective or unauthorized alternatives, potentially affecting their health and well-being. It's past time for Massachusetts policy members to place priority back on our patients. The medical card holders of Massachusetts deserve consistent local access to their prescribed treatments without unnecessary barriers. Together, let's ensure that the people who need this medicine the most are not forgotten. Thank you.
Emily, thank you. Hang on just a second. Anybody have any questions for Emily?
No, thank you so much, though, Emily. Thank you.
Commissioner, you all
Thank
set?
you so much.
Thank you for your time. I appreciate it.
Thank you, Emily. Appreciate it. Next, I have David Watkins. Okay. Jay D'Amico. Marie Cornell, maybe. Kevin Reardon. Okay. Kyle Rose. Kyle's there.
Yes, sir.
Hi, Kyle. I apologize. How do you pronounce your last name, Kyle? Okay. All right, Kyle, go ahead.
Hi, my name is Kyle Gross. I'm an active registered patient in the Massachusetts Medical Use of Marijuana Program and a disabled veteran with a VA rating of 100%. I would like to thank the Commission for the opportunity to speak today. I was introduced to medical marijuana spring of 2020, a little time into the COVID lockdown. Initially afraid of becoming a registered patient and being part of the system, I was persuaded by the advertised benefits of the program. No taxes, the rewards program and veteran discounts, access to knowledgeable staff educated to support a medical patient customer base, and the range and potency of the medicine. For the first couple of years as a registered patient, having access to quality products from a knowledgeable source at an affordable price, consumed in the healthiest and most efficient way possible, was life-changing for me. Excuse me. But when the first of multiple medical dispensaries closed temporarily to rebrand and reopen as an adult use facility, I was reminded of the days when I wasn't treated like a patient. But this time it wasn't my choice. Cost of my medical regimen for the first year in this medical facility was approximately $2,750. My would-be tab for the same regimen at the same facility, but now as an adult user, was going to be about $35,400 annually, an increase of over $32,000. And why? Because I was having to buy 10 times the quantity as I no longer had access to the concentration I needed. I was no longer allowed to receive a veteran discount or participate in a rewards program. And then I was hit with a 20% tax on top of it all. I spent time trying to become more educated on the legislature, statutes, and regulations before speaking here today. But when trying to put together my words, I found myself more lost and confused than before. If the mission of the commission as it pertains to today's topic is to safely, equitably, and effectively implement and administer the laws enabling access to medical marijuana in the Commonwealth, then why continue to allow so many restrictions on medical facilities? Vertical integration, insane licensing costs, capital resource requirements, no discount or rewards programs. And maybe my confusion is from a place of ignorance, but as a patient, I would have expected my access to medicine to be easier than that of an adult user. The social equality programs the CCC have seem great, but when your restrictions on medical access impact the minorities of those minority groups, it just adds to the assumption that income to the state trumps outcome to the patients. Again, thank you for your time.
Kyle, first of all, thank you for sharing your testimony. Thank you for your service, and thank you for your comments today. They're greatly appreciated. Any questions?
No, just thank you, Kyle, and thank you for your service, and we hear you. So thank you very much. Thank you.
Next, I have Emma O'Brien, Andrew Flaherty, Meredith Freed. Hi, Meredith.
Good afternoon.
Good afternoon.
I'm actually in the vehicle traveling today, so I apologize if I'm breaking up, but I will go as fast as I can. Good afternoon. I'm Meredith Freed from Swampscott, a patient since 2015. Given the time constraints, I'm going to try to get through as many points as I can. I have 6. I already submitted a more in-depth email for your consideration. A lot of my topics have already been discussed by a number of previous testimony, but I would like to reiterate my points. So number 1, every qualifying patient must be able to access medical cannabis irrespective of having a Massachusetts address. The statute has no residency requirement for patient qualification, and removing this will allow for out-of-state medical patients seeking care and transitory residents, unhoused patients on vacation, anybody who comes to Massachusetts and can become a certified patient to be able to access their medication. Removing this requirement could allow the CCC an opportunity to direct the system to automatically renew patient status once the licensed medical professional has authorized it. If CCC certified providers can decide a patient's status and length of time until the next follow-up visit and not an arbitrary regulation, you could change it from an annual to a multiple year license certification so that it could reduce costs for patient IDs as well. They wouldn't have to be renewed annually. My second point, the current fee structure offers no incentive to serve the finite medical market. As many people have said, the $50,000 license annual fee, with irrespective of canopy size, irrespective of whether it's just another dispensary or another fully integrated license, compared to an ME, pays $10,000 retail and manufacturing, and then for canopy size, it starts at $12.50 and then goes up to $50,000. It's time for the CCC to break down MTC licenses to accurately reflect the business footprint. In addition to the licensing fee burden, annual fees for MTC registered agents are $500. They're only $115 for the admin. That's a pretty vast difference just for an agent. It should be less. And we need to seriously consider waiving or minimizing these fees to incentivize participation. Third, the research data report that you just recently released showed that the price per ounce was $400 in 2018, and now it's down to $153. Medical patients have paid that price, $400 an ounce, for a year. And now as the price has become affordable, our access is dwindled. We want to shop tax-free. When I shop at a co-located dispensary, I find that I am often not given the same menu choices as the rec side, which has so many more brands and options. I should have access to whatever. It doesn't matter. The only difference between these products is the dose on edibles and tinctures, and flour and concentrates and vapes should be equally accessible. It's all the same. 4, continuing to listen to the CCC pat themselves in the back for allowing distribution to the island that did nothing to save the medical program there is a really tough pill for me to swallow. After all that, the medical dispensary closed. This is a canary in the coal mine. This was your way of knowing you need change now, yesterday. 5. The find a retailer function on the CCC website is so out of date. It shows so many closed MTCs is still open and available to customers. This needs to be updated in real time. And finally, we need access to low-cost samples for all products. We cannot afford to waste money on trial and error due to inconsistency with ever-changing cultivator strains. I appreciate this opportunity to speak with you today. Thank you.
Meredith, thank you. Any questions for Meredith?
Thank you so much.
Thank you, Meredith, for your thoughts. Drive safely.
Thank you.
All right. Next, I have, oops. Ellen Moore. Okay. Hi, Ellen. Welcome.
Okay, thank you. All right, here we go. Good afternoon, commissioners. My name is Ellen Moore, and I have been a medical marijuana patient since 2014, back when there was no way for patients to access their marijuana except through a limited caregiving system that did its best to help patients. Then the dispensary started opening and access was easier, but still not widely available. Now, currently, medical access is decreasing. Dispensaries are dropping their medical licenses at an alarming rate. This wasn't unforeseen. Legislation and requests for change from the CCC to remove vertical and capital restrictions hasn't happened, keeping social equity and smaller marijuana businesses out of the medical market, many who wish to serve patients. The failure to review regulatory recommendations and open meetings presented by your CABs and ones prepared by past Commissioner Kay Doyle to eliminate vertical integration shows a lack of urgency felt by the Commission. Furthermore, you are out of compliance with Chapter 180 by leaving foundational barriers in place that prevent social equity businesses from participating in the medical program, a clear goal of that chapter. Lack of action has led to lack of access for patients, and access is the primary purpose of the medical marijuana program, not generating revenue and creating unnecessary hurdles for us. Patients and caregivers can't even sign up for hardship cultivation. That was part of the 2020 regulatory period. Not sure what's around that, but anyways, we feel abandoned. Where there is medical equity, hold on. Where is there medical equity for disadvantaged communities? There are wastelands where patients have no access. We need medical care everywhere. Medical access is essential. This is a medical emergency, and we need an emergency administrative order from you that will allow all cannabis dispensaries to provide products to patients without paying tax until regulations are put into place to be in compliance with Chapter 180 and expand access to patients nationwide. As a patient, the cannabis I use, whether from a MTC or an adult use dispensary, becomes medicinal when I use it. The fact that all dispensaries don't recognize my medical card is a shortcoming of the program, and you have the power to correct it. Please look at Directive 91.5 in my written testimony that made medical marijuana not taxable, and over-the-counter purchases shouldn't be taxed either. Please, no delay, save medical today. Thank you for your time.
Thank you very much, Helen. Appreciate it. Thank you for joining us. Any questions for Helen?
Thank you so much. I'm still writing notes.
Thank you. All right, next I have Eric Morris. Okay. Chandra Batra.
Did you say Patricia Cooney? No.
Not yet.
Okay, sorry.
No, no worries. Jody Chapin.
Yes, I'm here.
Hi, Jody. How are you? Welcome.
I am great. Thank you. Good afternoon, commissioners. My name is Jody Chapin, and I have been a registered nurse in Massachusetts for 36 years and a medical marijuana patient for 8 years. Since 2018, I have also been an advocate and an educator for medical cannabis patients through the nonprofit Green Network Providers, of which I am vice president. Not only do we certify patients, but we also provide personalized medication reconciliation and education on their interactions and side effects to ensure that they can safely and effectively incorporate cannabis into their wellness plans. Today, I'm here to speak on behalf of the patients I work with, many of whom face unnecessary barriers in accessing their medicine. First, there is significant confusion surrounding medical card expiration dates. Many patients mistakenly believe the date printed on their card determines their access, when in actuality, it's the provider's certification date that matters. This misalignment often results in patients being unexpectedly denied medication at dispensaries. Compounding this issue is the cumbersome patient registration process. After receiving their certification from their provider, patients must then complete an additional step by registering separately with the CCC. This creates unnecessary delays, particularly for elderly and disabled patients and those who struggle with technology. The solution would be to streamline the process by integrating provider certifications directly into the CCC system, eliminating the need for a separate patient registration step. Then there's the lack of transparency around remediated cannabis. When cannabis fails testing, it often undergoes remediation through processes like radiation or chemical washes to then make it legally sellable. Patients don't know if their medicine has been altered or how it may impact its safety and efficacy. We need to require dispensaries to disclose those remediated products that they stock on their shelves. Then there's a huge need for more cannabis compassion programs like the initiative Beantown Greentown offers. Many seriously ill and low-income patients cannot afford their medicine or even regularly find the specific strains that they need. A solution would be to implement and support more cannabis compassion programs and create a caregiver-patient connection program to ensure reliable access to specific products. And lastly, some medical and recreational co-owned dispensaries have actually refused to honor medical pricing when a product is out of stock on their medical menu, even if the same product is available on their recreational menu. Medical patients should never be forced to pay recreational prices and taxes for their medicine. Ultimately, all dispensaries should be required to offer medical pricing on their products, but definitely co-owned dispensaries should honor it when unavailable on their medical menu. The Massachusetts Medical Cannabis Program was designed for patients, but these barriers are making access more difficult, not easier. Aligning expiration dates, simplifying registration, increasing transparency, and ensuring affordability are all necessary steps toward a truly patient-centered program. I urge the Cannabis Control Commission to take action and implement these changes. Thank you for your time and consideration.
Jody, before you go, a couple of questions. You talked about a cannabis compassion program and then a caregiver-patient connection. Can you give me a little more details on your thoughts on those?
For the patient connection program, oftentimes because dispensaries can't offer the same products all the time, and if patients can be connected with a caregiver that grows, they can grow a specific strain for these patients, and they can get this product on a regular basis rather than just trying to dispensary hop and not being assured that they can have access to a product that's helping them mitigate their disease.
Thank you, Jody. Appreciate that. Any other questions?
No, thank you so much. Love this sweatshirt.
Thank you, Jody.
Thank you. Thank you so much for your time.
All right. Next, I have Dr. Benjamin Kaplan. Okay. I have Leslie Laurie. I have Alan Jaffe. And now I'm up to Patricia Cooney. So welcome, Patricia.
Oh, thank you. Just let me pull over. I'm in my car because I didn't expect it to be this long. I'm sorry.
That's okay. Please pull over and be safe.
Hold on. I just did not. All right, I'm gonna pull over right here. Thank you so much for your patience. Let's see. Yes. Okay, let me just start. Thank you. Hi, my name is Patricia Cooney, and I've been a registered nurse for many years. However, it wasn't until my daughter's battle with lupus that I truly understood the power of medical cannabis. Back in 2011, she was hospitalized for 5 weeks and in terrible pain. She told me, "Mom, I feel better when I use marijuana." That changed everything for me. I started to learn about the endocannabinoid system, a vital part of human biology that's responsible for maintaining balance in our bodies. It's the key to understanding why cannabis works as medicine, but only 13% of medical schools teach about it. Even my daughter's Harvard-educated doctors had never heard of it, but they have because of me. As a nurse, I found that unacceptable. So when Massachusetts legalized medical marijuana in 2012, I was hopeful, but it took over 2 years for the first dispensary to open. When I brought my daughter there on opening day in Salem, Massachusetts, she had to register as a patient, be working, and pay out of pocket for her medicine, and I wasn't even allowed to go and assist her. Once inside, she was led on her own to figure out strains, choose how much to take, and the best way to use it. I was relieved that you could find good access to quality product, but the barriers were shocking to me as a nurse. We need to do better. Our North Star needs to be our suffering citizens in Massachusetts, where cannabis can relieve their suffering. Now, a decade later, our medical program is facing a real emergency. In the past year, 12 medical dispensaries have closed. This is forcing many patients to turn to recreational dispensaries and pay taxes on the medicine. Each time a medical dispensary shuts down, patients are losing access to what they've come to rely on. They are forced to start all over again to figure out which products work for them and where to access them. This involves costly, frustrating, and trial and error. The Cannabis Control Commission is supposed to be protecting patients, and yet the biggest barrier to access is our own regulations. The fact that even 10 years after the first medical dispensary opened, the commission still requires medical dispensaries to grow their own cannabis unnecessarily, restricts who can get a medical facility. This is making it harder, not easier, for patients to get the care they need. Patients need more access to medical cannabis, not less. The solution is straightforward. Let any dispensary add a medical register. That way, patients can access the medical program anywhere instead of watching it disappear. In my everyday life, I teach everyone who will listen about the endocannabinoid system, from physicians to fellow nurses and colleagues. I'm a member of the American Cannabis Nurses Association, and I graduated from the University of Maryland School of Pharmacy, Medical Cannabis Science, Therapeutics. And we need to help our patients. This is truly medicine. And I'm speaking at the MNA, their conference in May, with Dr. Aaron Walsh, who's a pharmacist. We both graduated from this program. We would love to educate the Cannabis Control Commission on the true medical applications of this medicine that our patients need. My daughter, she was supposed to speak, but I had to come out. She was just got discharged from the hospital. And she voiced some of the same concerns. And when she goes into a rec and a medical dispensary, she has to, her product isn't there, she has to go through this process where a manager has to go over to the rec card. It takes like 20 minutes. She's in pain. I actually had to, since she had a lupus flare, she was hospitalized at the Brigham for 5 weeks, 6 nights, she just got out. My husband just got out of the hospital. I'm picking him up. He teaches at Malden Catholic High School. I'm on a family medical. So she was in pain. I went up to Kittery, Maine to go to the medical dispensary there. They had the quality and the variety of products they had for patients was amazing to me. The three big reasons people go to use medical cannabis is pain, insomnia, and anxiety. And that dispensary I went to didn't have one for sleep. Now and it's medical and recreational, and it's just so evident that the two together, the priority is recreational. I have no problem with recreational, just using it safely. But our North Star needs to be the suffering people in our community here in Massachusetts who get relief from medical cannabis, from peripheral chemotherapy-induced peripheral neuropathy, pain from lupus. My daughter has lupus very severely, and I made this I'm a school nurse, I am a sexual assault nurse examiner for the state of Massachusetts, and I'm a cannabis nurse. And it's just so, we need to treat this as true medicine, and these people need care. They do not get medical care. Thank you for your time. And my daughter, she can't be with me to pick up my husband. She did have she had something to say, but she couldn't join me in the car because she's just got out of the hospital. She's not even walking totally yet. So thank you so much.
Patricia, thank you, and appreciate you sharing your story. Couple of questions if you have a minute. You shared the story of your daughter going to a dispensary up in Salem and that you weren't allowed to go in with your daughter and be with her.
Yeah, that was the opening of the first one in 2015, the first opening of Salem, Mass, when it first opened, and I didn't get a caregiver card yet, so she had to go in by herself.
Can I ask you how old she was at the time?
Oh yeah, she was 22.
Okay.
23, 24, yeah, but she's in pain. You know, I'm a nurse, I can help her. She's sick, she's very sick, and to negotiate routes of administration, dosages, no one does an intake. There's no intake on drug interactions, which there's over 365 drug interactions that you need to assess for.
Right.
There's no medical care given. And I would love with Erin, we have Dr. Dustin Sulak. I hope you've heard of him. If you're managing a medical cannabis program, you should know some of the key players. Dr. Dustin Sulak in Maine. He's the medical cannabis expert in the world. Healer.com. His website hits all the marks for medical. And it is a nursing specialty now. We have our own scope and practice book. It deemed in the American Nurses Association and the American Cannabis Nurses Association as deemed medical cannabis a nursing specialty as of September 2023. And we need to get on board with people we need to help people and service them appropriately and medically and safely.
Patricia, I'd also ask, if you want to send us the information about the event you're speaking at, I think we'd all be interested.
Oh, it's Massachusetts Nurses Association, their conference in May. And Dr. Erin Waltz, she's a pharmacist at Lowell General. I'm 67, she's like 27, but we relate very well. And we're going to give a presentation on medical cannabis. She speaks to people also need to know that if you're using it, whether it be recreationally or medicinally, if you're gonna have surgery, you need to tell your anesthesiologist that, because you might need more anesthesia.
Right.
So, and, so she has spoken to, anesthesiologists on that part of it, but these are just some of the, concerns and things medical people need to know, to even take care of people for other reasons. But if people are using this method, whether it be recreationally or medicinally, you need to disclose that for your own care and safety, and it's legal.
Yep.
But there's so many complexities, and I spent time getting a master's degree in it because I was just so upset that they don't use our state, like I call it medical malfeasance and educational malfeasance, that we don't teach the endocannabinoid system. I mean, our National Nursing Board wants all nurses to learn about the endocannabinoid system. I don't care whether you agree with medical cannabis or cannabis, but this is the system that is in our body that we've known about for over 30 years. And it's fairly taught, and it's the dominant system in our body. And anyone who's managing a medical cannabis program should have a library and resources on the key players in this and what's going on. I mean, there's a rich culture, even in Massachusetts, of doctors and nurses who are wanting to learn and teach. We want to help people not suffering. We all already, see, the driving force behind medical cannabis is parents of sick children, which is item one. And that's why we have Epidiolex is FDA approved for intractable seizure disorder in children. And that's why CBD is pretty much, which is non-psychoactive, but it helps kids. They're using it for autism as well. One of my classmates, one of my heroes, her son has severe autism at age, he's on only one psychotrope and he uses this medical cannabis. She went to the program I went to, master's degree, and they have a better quality of life. This is what medical people in the cannabis domain see, and we want to educate, we want to help people who are suffering, because it could be you next tomorrow or your loved one. And if this can help them sleep at night, if they're experiencing chemotherapy-induced peripheral neuropathy, which I did my little project on CBD cream, my old boss retired, that helped her so she could sleep after she went through cancer treatments. CBD cream. Some of the PO meds don't do anything for those things. And she was able to sleep and walk and be more, have more normalcy. That's all, we want to do. I actually have to get to my husband. But I really appreciate you listening to me, and I would love to speak in front of your group, and I will let you know about where we're speaking. I spoke at the Massachusetts Hospice and Palliative Care Association conference a year and a half ago. So that was good, and I've talked to the Massachusetts School Nurses Association as well.
Patricia, do you have a few more minutes? My colleagues want to ask you a couple of questions.
Sure.
Commissioner Camargo.
Yeah, thank you. Patricia, I know you got to go, and I know we're over our time a little bit, but my comment was, feel free to send in some comments. It's always very welcome and very helpful. So we have them on record, so we can put them on record in terms of in writing. And then also your daughter, encourage her to send something as well. It would be great to hear from your daughter as well. So thank you so much, and I hope your family will be better soon.
And also, I did give a book to Jeremiah to give to one of the commissioners there, Dr. Dustin Sulek's book, which is dedicated to his patients, and the scope and practice book from the American Nurses Association.
Patricia, we did get the book. It is now officially part of the CCC's library. So appreciate you passing that along.
Thank you so much.
Commissioner Roy, go ahead.
Yeah, and thank you for your testimony, Patricia, and sharing your daughter's story with us. And is the conference you're referring to in May in Westboro? Because Chief of Staff Andrew Carter and myself were talking about it yesterday, and we want to attend in some capacity, whether we have a educational table, we speak. Is that the same conference? Do you know if it's in Westboro at the Doubletree?
No, this is in North.
Okay, if you could send us information on that, and if you want us to participate in any way, whether it's an educational table or having one of us go out there and speak, please let us know. Thank you.
Thank you, Patricia. Best to you and your family.
Thank you. Good night.
Okay. Next I have Elizabeth Kremen.
Oh, that's my daughter.
Oh, okay, okay.
So she's not able, so I kind of spoke what her concerns were, so.
All right. We certainly, as Commissioner Camargo said, she is certainly welcome to send in any thoughts she has as well. Linda Noel. Okay. Hi, Linda. How are you?
Pardon?
How are you? Can you hear us okay? We can hear you okay.
Yes. So today I'm talking about the medical marijuana program for treatment. I've been a patient since 2015. Cannabis is my medicine. It's one of the few medicines that I can take because of my immune system. And I'm doing FEMA and according to my dose person, trying to do right now. And I require epinephrine. I walked away from 20 years prescriptions with you. When I became a resident, 10 years ago, I have other complicated factors and cannabis has been always. The IgG deficient. Basically, I don't know one different even though I have myself. I was down to Renewals and COVID. And actually, my immunologist and my GP both prescribed cannabis for the condition. I went off the record because they are doctors, and I'm not strictly allowed to prescribe it. My cannabis, I couldn't without it. I'm here to testify today because the main problem with type 1 marijuana program is neural. Right, there's the law, the ability to in your power to make this right. Some of us can't afford that 28th difference, the problem in medicine. I'm going without it, believe me, and there's this kind of pain, you need to go without. I need to implement the de-radicalization now. I understand Captain gave you the power. I am also but yes, the applicants need to be allowed to open standalone treatment clinics and sell the same products as rec at the same prices as rec, since the prices are the same. I know that you made extra in the case of Cannabis when it was stated that the dispensaries could sell her product because we modified 94G. And we forgot to modify 94I. But yet, the regulator allow the entities to do the same thing. If you have power that you use. Now, I do urge you to implement the regulations for action consultation. It was passed 5 years ago. I am not quite clear why anyone would object to it. This is necessary for patients like myself who can't access a dispensary. I myself can't go into one because I can't go into a public place without being infected by something. I am a bubble person. But additionally, there's people who have said that we can't get there, who do cultivate at home, who require 60-day supply to be available. And you have determined that is 10 ounces. That is not possible if you go to 6 plants. I'm sorry, my grandfather grew 6 hemp plants. That's 6. That's the best I could do. The best care we could have. Hydroponically treated like full time, one time per plant. If you're growing a low plant in the fall, I can grow it. Then you might be able to get it if you are lucky. So we need that's the reason for our patients need to be able to the doctor either determination what they need. Please. Doctor has been 5 years and 94 marinate partnership consultation. That's inexcusable. And finally, you have doc, my real fix the labs. The reason and it almost killed me. So I will open until I can be confident that my immune system is functioning as the government. So, thank you for all the good stuff that you have done. And I want to thank you very much for
Thank you, Linda, very much for your time.
Thank you, Linda.
Linda, thank you so much.
Next, I have Aaron Little. All right, and then I think last sign up was Jessica Fiascanero. We also have Elizabeth Palmer agreed to join us virtually. Is Elizabeth with us? Hi, Elizabeth. How are you?
Good, how are you? Thank you, Commissioner, so much for your time this afternoon. I know it's been a long day of testimony. Let me introduce myself. I have not had the opportunity to be a part of one of these meetings before. My name is Liz Palmer. I've been a patient since those with chronic migraine have been allowed to get a doctor's recommendation for cannabis. I don't remember what year that was, but it wasn't in the very beginning. It was later on. My diagnoses also include epilepsy and fibromyalgia. Sitting here for 4 hours, I apologize if I'm a little messy and my pain's been increasing. I'm also have this unique perspective that I've been a member of the Massachusetts cannabis industry since November of 2018. I started as a cultivation tech. I've worked as a dispensary bud tender, patient admissions, and now I'm a marketing director. So I wanted to come here today, and I really struggled with how to phrase this. And I've been listening, and everybody's been talking about high level things. So I wanted to take you through a ground level experience of what it's like to be a patient simultaneously explaining to you why businesses are losing money. Because I've been a part of this industry long enough to understand both sides. So I'm going to take you through a typical patient journey very quickly. So until very recently, I lived in the lovely little town of Sturbridge for most of my life. And in order to secure the right amount of medicine and the right dosages and the right products, I needed to make a 102-mile round trip between 3 dispensaries to secure all of the medicine that I needed. And I am very grateful to have the privilege of having a car. I cannot imagine what other people who lack public transportation in that part of the state, what difficulties they must go through in order to secure their medication. There was one delivery dispensary out of Worcester that was willing to deliver to me for a minimum delivery amount of $150. So those with high incomes, that's not an option. Not to mention they can't get their medicine if they're living in public housing or a variety of other areas that have been blockaded. So in addition to that, before I walk into a dispensary, because delivery is not an option, I often log into Mass CIP because more often than not, throughout the years, I have gone to get my medicine and Mass CIP has been down. And I can't be dispensed my medicine unless I go to the recreational side. I also have an extended allotment of 12 ounces over 60 days. So I always like to check my allotment before I go in because concentrates and infused pre-rolls are way too much in regards to what a patient needs. Also, while we're on the topic of Mass CIP, the elderly cannot what's on there. It hasn't been updated in years. I think it's the same system I was dispensing out of in 2019. After I check my allotment, while I'm checking in, by the way, as a patient, that barcode in the back of our gate does nothing at dispensaries. So they have to manually input my information. While they're checking me in, they can check in 5 recreational customers. So already I'm costing them 5 rec customers as a medical patient going into a dual use facility. Again, when I'm picking up my pre-ordered product, because of all the red tape the CCC regulators have put into place, while I'm checking out or waiting to be checked out, that's about 10 to 20 minutes because of the process of double checking inventory, double checking my allotment, double checking my ID. I feel like a second-class citizen while I'm watching 5 to 7 recreational customers getting checked out with the same amount of product that I'm getting checked out with. And you're wondering why businesses aren't making money off of medical patients when that wasn't the intent to begin with anyways, but now you see why they want to open up just recreational. Not only that, it's such a long wait time. There's no regulations to allow disabled, physically disabled like myself to be able to sit down for those 15, 20 minutes. I rarely see an ADA compliant counter for people with wheelchairs or walkers to walk up to. The list is so long on why this takes so long for patients to be processed in the transaction system. And not to mention, you're costing, the business is spending more money when a patient like myself does need medication from the recreational side. They have to pay for the extra destruction of metric tax. That's personnel time. And it takes about 10 to 20 minutes through the metric system to transfer one product from rec to medical. And that's because of the red tape y'all put into place. It really, truly is. And this, I speak because I used to work behind the counter as well. I do this at one dispensary. So my typical check-in, check-out time is 30 minutes. And I have to do that 2 more times over, at least once a week. It's so much more time. It's no wonder why people like my dad, who has a spinal cord injury, no longer want to be a patient because it's faster to go get checked out as a recreational customer. There's immediate relief that everybody has already told you about. I actually bullet pointed some stuff I emailed to you in advance. It's not gonna solve it all for some short-term things like, you know, we can simplify the metric inventory process in the back end. Do we really need that many metric tags? Do budtenders need to be both badged for medical and recreational? Because there's times when I've walked into the dispensary and they're like, we don't have any medically badged employees on today. So they couldn't serve me. That is a problem. And no wonder why they don't want to double badge. It's costing them thousands of dollars just to keep people employed on their floor every day if you're a dual use dispensary. The only reason why we're in this crisis is because of the CCC. There are other programs that do it right. People have mentioned Maine. I go to Maine at least once a quarter because I can't get high dose CBD and THC in Massachusetts. I cannot. It's not profitable to the companies I've worked for in the past to make those medication products. And it doesn't matter because at the end of the day, I'm not paying that 20% tax. I will get my Nation card in another state if I have to and continue to be purchasing that way because right now, this is my medicine. It's not a recreational drug. And I've also emailed you my phone number, so if you'd like to talk further, I'm more than open to that discussion. Thank you.
Thank you, Liz. Any questions for Liz?
Thank you, Liz.
Thank you, Liz.
Can I just make a comment? Oh,
Good.
well, I'll make the comment. Liz, I don't know if you're still on, but, oh, thank you. I just want to say thank you for bringing, it sounds like you heard all the testimony this morning and you are testifying on some of the gaps that are on the ground. And like you said, it's like folks that were testifying are also patients, but you're giving us a on the ground perspective. So I appreciate your testimony and how you sort of rearranged it for us and the storytelling. That's very helpful. And you just made me think about the sitting when you go into a dispensary. And I just sent a message to our team right now. You know, we're working on social consumption regulations, and it just made me think about that component of it for, for folks. So thank you, and thank you again. So that's it.
I mean, we need to really address what's going on in the dispensaries with medical patients before we even think about social consumption.
Yeah, I hear you.
We can't get our medicine.
Yep.
My dad is no longer a patient. He went black market because he can't stand for 20, 30 minutes in dispensary.
Right.
And this is red tape. These dispensaries did not create. The CCC did.
Yeah. Thank you so much. I appreciate the perspective.
Thank you. Commissioner Roy.
Liz, I have a question for you. You didn't mention it, but you're very well versed on both sides of the ledger, having worked in the industry and also being a patient. And I've been focused lately on certificates of analysis. And I feel that's incredibly important for patients and consumers to have access to make informed decisions, right? You need information to make informed decisions. So what's been your experience? Have you tried to procure a certificate of analysis? Do you feel there's an ease? Is there like a disconnect in the system?
So COAs, don't let businesses fool you. It's not that hard to post. I work for Bay State Extracts. Our COAs are posted directly on our website. It takes me 5 minutes to change it out. It took my website developer to create the portal for me, but it's really not that hard to post a COA. A QR code that could be stickered. Don't use the printer labels. They're terrible in the dispensaries. A separate sticker to be placed on top of the jar, on the bottom of the pre-roll for somebody to just click, boom, brings up the producer's website. Let's say it's Bay State Extracts. They want to know their CBD content. And that QR code pops up the web page of the COA that's in a PDF. Bam, done. It's not that hard.
And how important do you think that is, in your opinion, for patients to? I agree.
Talking about remediation, I actually have a physical reaction when I smoke remediated products. I cough up brown and gray mucus within 12 hours, and I have friends that have allergic reactions. I've actually worked in multi-facilities. I can't speak to those because of the NDAs that I have signed, but it does exist, and we need to know this information. We need to know, Was it treated for pesticides? I'm allergic to stuff that is still even approved by means products. Some people have actually citrus allergies. So some of the byproducts used in IPM management, people are actually allergic to. And it's rare, but that's information still needs to be available. I want to know if something has CBC in it. It's not one of the cannabinoids that often gets tested, but it's one of the most helpful cannabinoids for me. And that doesn't get included on that tiny half-inch label that we make producers apply.
Liz, I just want to follow up. You said you need to know you get a reaction for remediated products. What about pre-irradiated products? So there's a difference. And so some products are pre-irradiated, and then some products fail and then get remediated. So are you kind of putting them all in one? You'd want to know either way?
Know the difference because I don't know the difference, and I've been in the industry since 2018. That's how little education has been brought to those who are not only marketing like myself, but the patients who are trying to understand. We're not all experts, and there's so much that we don't understand. That's why we need a COA.
Exactly. Well, you do need COA.
So that you can understand the difference. And I got something to Google this afternoon. Thank you, Commissioner.
What? Say that again? What was that last line?
Thank you. Gave me something to Google.
Oh, okay. You're welcome. I was like, I didn't want to. All right.
Who ended up on Google?
I know. That's what I thought it was. Yeah. So, all right. Yeah. Well, that's helpful. I think we need to contemplate the access to COAs. I think it's especially with social consumption. And so anyway, I appreciate your feedback and the importance that you placed on them as well. And I think QR codes have a pivotal role in the future of cannabis products as well. So thank you.
Thank you, Liz. Appreciate it very much. Chandra Batra has joined us. Chandra, we're having a problem hearing you.
No.
No, it's a little broken up.
You can always send it in if you don't have a good connection.
Chandra, you can always email in your thoughts or your testimony today. We're just having a hard problem hearing you. Okay. Next, I have some people kind of joining us late. Just bear with me. Is Jessica Fiascanero? I called her name once. Is she with us, Jessica? Hey, Jessica, how are you?
Good, thank you. How are you?
We're great. Go ahead. We don't want to cut into your time.
And as a wheelchair user, I have yet to see any dispensary have a handicap button to obviously make it more accessible for me. And I don't know whether that is like a security issue. I've brought it up to people's attention before, and I haven't really gotten a clear answer about how that can change for those of us that cannot open doors on our own. And another concern that I've had is there are some dispensaries that have lifts to get from the first floor to the second floor, and a lot of them don't know how to operate them, which can be pretty scary if that's your only way to go in and get your medicine, to be in a lift that may or may not break down at any moment because nobody has run into a patient actually needing to use one. And then I have 2 more points that I'll wrap up and be brief. I don't agree with how certain dispensaries will not allow you to use your 10% financial hardship discount on top of other discounts. When I leave the dispensary with my medicine or not, at the end of the day, I'm still gonna have financial hardship. So I don't think that that should be preventing patients from accessing more affordable medicine. And then my final point is the way that the menus are traditionally set up at dispensaries are usually on iPads, which don't extend. So I'm not able to reach them and use them to view the menu. And I have to use my phone, which can be very inconvenient and take up more time than other customers because they're waiting for me to read the menu since the one provided is not accessible or within reach. And that is all.
Okay. Jessica, thank you very much for your time. Anybody?
Thank you, Jessica.
Thank you, Jessica.
Thank you, Jessica. All right, I'll go back. A couple of other people have joined us. Peter Lynch.
Yep. Do you want me to address?
You can come up here, Peter, and use the, just push the button on the microphone. You can use that. Oh, wait a minute. Peter, you're in person. My apologies. Let us wrap up the virtual folks first.
I think Jessica, you need to disconnect or. Yeah.
And Linda Noel, is she the last one?
No, she's one.
Oh, Sharon. Okay, we're good. Okay. Now we just need a quick break so we can come back to being in person.
Oh, seriously?
Yep.
Oh, technical swap over?
Yep.
Okay.
All right.
We gotta switch the.
Just give us a few minutes. We'll reconvene at 2:55.
Thank you guys for the free copy.
The room's not rated. What you saying? The room's not rated.
All right, Peter, welcome. Come on up. Peter Lynch.
Hi, my name is Peter Lynch. I'm a current patient in your medical cannabis program. I'm 45 years old. My first time I started growing weed was when I was 13 years old. I've been growing pretty much most of my life. Grew up in northern Vermont. Was very heavily involved in the black market for many, many, many years. In doing so, to deal with the stress of the lifestyle, the constant threat of being put in jail. Most of us acquired serious opiate addictions, serious benzodiazepine addictions. I had a friend who had gone to jail, got caught again. Instead of going back, he decided to take his life. I know many, 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 many men who spent a lot of time in jail or died from overdoses from the drugs they were taking. I luckily was able to remove myself from that lifestyle and to heal myself and to get clean and totally change my life. I did so, moved to Europe, and I joined like a cloistered community and lived basically outside society for a very, very long, for almost 4 years, growing our own food, animals, totally removed from society, no TV, no newspaper, no outside influences, just living life in the moment and living a beautiful, beautiful existence. I stayed sober for about 10 years. And then I started drinking. And I used high dosage of psilocybin mushrooms to break the cycle. And then after that, have been maintaining and using edibles and cannabis and rosin or whatever. This is medicine. This is serious medicine. This is for humanity. This is for that girl in that wheelchair. That's why this is here. That's why you are here. It's not to make money. It's not to make profit. The plant doesn't want that either. The plant doesn't react to that. There's so many, I know a lot of friends that are in the industry. I've had so many opportunities to be in the industry. I had no desire to. I don't want to be involved. This is something spiritual to me. I grow very, very, very good medicine. Very good organic living soil medicine. What most of these patients receive is not medicine. It's poison. You heard that lady. She gets an allergic reaction to product that has been remediated. It's sprayed with not sprayed. It's treated with radiation. It's not healthy. No one should consume that. People have reactions to it. 55% of the product, not just the medical, but the recreational product on the market is remediated or should be remediated. And all of the companies, if they don't get tested, they just go to another testing company. So right now, MCR, big, one of the first testing companies, they're suing about 5 other companies for falsifying their tests. So if you got, big multi-million-dollar company, you're not just going to sit on your product. You're going to find someone to pay to fudge your tests and put it onto the market. For the medical industry, I think that right now, both New York and Vermont are proposing a farmers market style things where not even the big producers can do it. Even they are encouraging this. It's been implemented in Maine since the beginning of their medical program, and it's so robust. There's so many of them that they're actually there's too many now. There's too many options. So but it works for them. I think the barrier to get into the medical cannabis industry needs to be lowered. I saw a proposal that someone was proposing $1,000 license, which I totally support. Right now it's $55,000. No, but most people aren't going to spend $55,000 or $50,000 to receive a license. I would love to participate, and I would love to share my medicine to help people. It does incur a cost, doing it isn't free. It's, time consuming. Like, you need to be able to compensate it for your medicine and not just, share it for free to other people. Somehow, I think you should implement some type of program where patients can share with each other, can share their medicine with each other. It's about them. It's not about money at all. I think that's all I got. But I would love to, I have a lot of friends that are in the industry, and to get a good product, like I know like $30 million facilities that, like, before they opened, all their HVAC like sat, and all this mold and stuff, accumulated it. And as soon as they fired everything up and put plants in it, that just contaminated everything. They just spent $30 million. You think they're just going to throw it all away? No, absolutely not. That all went onto the market, all of it. Solar Cannabis, one of the better cannabis companies that I thought was like doing good things. I just saw they have a huge pest infestation in their facility that's compromising their production. Another thing is the amount of electricity, like, you need to encourage people to grow outside. We have a free source of electricity that is way better than any artificial source of sunlight. Right now, the cannabis industry takes 10% of the power from in the state. That wasn't there before. That 10% wasn't there. We added another 10%. I don't think that's very good for our environment. I don't think that's sustainable. I have a private municipal power company in our town, and the company in our town, they spend $75,000 a month on power. That's crazy. There's a free source outside their window, and the medicine that's produced by the sun is so much better. I know there's a lot of safety concerns and security concerns. I mean, what they do in Maine is you either have a plant count, you have, in the medical system, you either have a plant count, I forget what it is, maybe like 50 plants, or you have a space, 500 square foot space. So you can grow a plant, you can grow 50 plants outside, and you can grow them huge. You can get them big if you want to. Or you could grow in a 500 square foot space, which is, once the plants get large, the quality of the medicine diminishes quite a bit. The medicine produced by smaller plants is much better. So you can produce almost the same amount, in a 500 square, but using more plants, so you can put 1,000 plants into a 500 square, you can flower them when they're very small. It's much easier for the producer, it's less work. You can produce more actually that way. If you're cycling the, plants more, if you're doing it with big plants, you can maybe get, if you're doing light depth, you can maybe get 2 harvests. Most of them just do it, full sun, full term, and you get 1 harvest a year. Do you have a question?
Yeah, go ahead.
Peter?
Yes.
Lynch, yeah?
Yeah.
First of all, thank you. Not to interrupt you, but I wanted to, because I'm looking at the timer, we're already at
I'm
almost 9 minutes, it's okay. Because it didn't go off, so I kind of turned on my. I believe you're the last in-person person who's going to testify, but I should say thank you. I heard you say you've been growing cannabis since you were 13.
Yep.
So you definitely have a lot of experience. But I also would encourage you to put some stuff on paper for us that you think we really like. I always say kind of pick the top 3 things that you make that are important to you that I think that could be helpful for us. Because I'm hearing everything you're saying right now, but I'm also like I'm also just, it's working. I'm also just thinking in terms of your experience and your perspective, making sure that it's not lost. Have it also in writing.
Yeah. One of the reasons I started growing when I was 13, many men who were tied up in drug addiction or alcoholism, we were abused when we were young. I was sexually abused at a very, very young age. Mm-hmm. And that's probably one of the reasons I, started tried to escape from,
Well, thank you for sharing. That's, I'm sorry to hear that. Yeah, thank you.
But that's, many of these guys like on the streets around here, all these guys doing fentanyl. I sell food for a living right now, and one of my customers, the cops asked them to keep fentanyl in their kitchen because across the street is a park that people overdose every day, and it as a way to preventative measure, they asked if they could keep it in there, so like because the guys would always come over to them and call them, hey, can you call the cops? One of my buddies, so they just like gave him Narcan, sorry, no, they're not giving him fentanyl, gave him Narcan, so these guys, like, they're like escapists. I was, but like the medicine they're getting, it's not medicine. They're not getting high off of it. You need good medicine, like good rosin or good edibles, like full spectrum, not just like the distillate that's out there and all these. It's just THCA, and it gives you a super bad headache, and it makes you paranoid. And
Yeah, I appreciate where you're coming from, because I know what you're saying, and I know we're running out of time. No, it's all good. Well, until the boss says we're not good, but I get you and I hear you, and I'm grateful for you. You said something earlier, and I don't know if I wrote it down, but you talked about, this is a spiritual, plan, or, you said you got into a little bit of that, but this is a plan. I've said it all the time, right? It's a plan, and we always have to be cautious and mindful of the business aspect of this, and unfortunately, we're on the business side of it and the regulatory side of it, so it's very difficult. But I just want to thank you, because I hear you, and I'm listening to you in terms of your story, and I really appreciate your perspective, especially as someone who's been within that, who has that lived experience. I'll just say that. So I'm gonna shut my comments down, but feel free to send anything to any of us or to our our main email. I want to say thank you. So thank you, Commissioner Stebbins. I know we're way past now. You're at 11 minutes.
Sorry, I'm good.
Thank you.
Thank you. Appreciate it. Cool.
Thank you, Peter.
All right.
That's your last line.
I think that is it. Getting the yes from Jessica. All right, we have some regular commission business to attend to. Annie, thank you for hanging in there. Good afternoon.
Hi, how are you?
We're great. Long day,
Okay.
but we are happy to move on to changes of ownership.
Yeah, no, it was great to listen to that today. So, yes, we do have some votes today. So today we have two changes of ownership. The first being the House of Armias. They're seeking a change of ownership and control over one adult use license and are requesting to add 3 individuals. Additional information is contained within the executive summary for the Commission's review and consideration. Therefore, Commission staff recommend review and decision on this request, and if approved, do request your approval be subject to the conditions before you.
Okay, thank you, Annie. Any questions on this change of ownership? Seeing none, I'll seek a motion to approve the change of ownership of House of Armias LLC. Do I have such motion, Commissioner Camargo?
So moved.
Do I have a second, Commissioner Roy?
Second.
Motion been made and seconded. Any further comments or questions? Seeing none, I'll do a roll call vote. Commissioner Camargo?
Aye.
Commissioner Roy?
Aye.
And Commissioner Stebbins votes aye. 3 in favor, none opposed. Okay, Annie, take us to the next one.
Thank you, Chair. The licensee here is Leaf Relief Incorporated. They are seeking a change of ownership and control over one adult use license and are requesting to add 1 individual. Additional information is contained within the executive summary for the Commission's review and consideration. Therefore, Commission staff recommend review and decision on this request, and if approved, do request your approval be subject to the conditions before you.
Any questions from my colleagues on Leaf Relief? Okay. I'll seek a motion to approve the change of ownership for Leaf Relief Inc. Do I have such motion, Commissioner Roy?
So moved.
Do I have a second, Commissioner Camargo?
Second.
Motion been made and seconded. Any further comments or questions? Seeing none, I'll do a roll call vote. Commissioner Camargo? Commissioner Roy?
Aye.
And Commissioner Stebbins votes aye. 3 in favor, none opposed. All right, we'll move on to staff recommendations on the licensing renewals. We have 34 license renewals. I have some conditions. I didn't receive conditions from others. I'll quickly go through my conditions. The first one is for Calverde Naturals, LLC, MRR 207163. My proposed condition is within 30 business days of approval of application for renewal, contact CCC Licensing Division and provide response on whether licensee would consider potential changes toward goal number 1 in licensee's positive impact plan in accordance with 935 CMR 500.1034B. Just a quick explanation. This is a licensee located in Belmont. Part of their positive impact plan is trying to recruit employees from Fitchburg. They've noted challenges in being able to do that, especially considering that Fitchburg itself is home to a number of cannabis licensees. My question to them is, do they want to rethink their positive impact plan? The next licensee I am proposing a condition for is the Fresh Connection Boston LLC, MCR 140885. Proposed condition is within 30 business days of approval of application for renewal. Please respond and report on progress and success toward hiring goals of veterans and persons with disabilities and diversity plan in accordance with 935 CMR 500.1034B. And my next 2 conditions are for HVV Massachusetts, MCR, hang on a second. License numbers RMD 1185 and RMD 1405. And my proposed condition is within 30 business days of approval, application for renewal, provide to CCC Licensing Division a response and evaluation of how new diversity plan complies with 935 CMR 501.1034B. So other than those conditions, I don't have any others, but I would seek a motion to approve the renewal licenses subject to the conditions articulated by Commissioner Stebbins. Do I have such a motion, Commissioner Camargo?
So moved.
Do I have a second, Commissioner Roy?
Second.
Motion been made and seconded. Any further comments or questions? Seeing none, I'll do a roll call vote. Commissioner Camargo?
Aye.
Commissioner Roy?
Aye.
And Commissioner Stebbins votes aye. 3 in favor, none opposed. Thank you, Amy. Are we all set?
Thank you. That was it today.
All right. Thank you very much.
Thank you.
All right, we will move on quickly to commission discussion and votes. We have one item under commission discussion and votes. We have a job description for a data analyst. This is being presented by our Chief Technology and Innovation Officer, Paul Clark. Many who saw him running around today already, but Chief Clark, go ahead. We invite you to talk through the job description that is included in the board meeting packet.
Great, thank you. Good afternoon, commissioners. Thank you time for the opportunity to present this data analyst position. The data analyst position would be part of our data analytics team, reporting to our Director of Data Analytics, Dr. Marianne Sarkis. The primary purpose, the focus of the role is to assist in doing reporting and data analytics, providing data and visualizations both through our open data platform, but also for internal uses. The data team is routinely getting increased numbers of requests for reports, data analysts, data analytics, visualizations, assisting with our investigation and enforcements, as well as increased requests for our open data platform that we would like to continue to expand upon. This role would be a functional role, performing a lot of the data transformations and work, allowing our Director of Data Analytics to focus more on building out of our data analytics platform and be able to work on expanding our open data visualizations and graphics. Pretty straightforward, I think. We're looking for someone with some experience in some areas of data analysis and data analytics. Would be open. This is a position that was originally is in the FY26 budget, but we're swapping out with a position that's in the FY25 budget. It would be a budget neutral swap. Is we prioritize that this is a much more needed position than the position we have had that was previously approved for support of our Microsoft Dynamics environment and development in that area. So any questions that I can answer for the commissioners?
Commissioner Roy, go ahead.
Thank you, Chair, and thank you, Paul. How critical is this position to our mission?
I would say it's extremely critical at this point. Not only is the data, and I neglected to mention, one of the increased workloads we're seeing with the data analytics team, not only in support of Chapter 180 and other regulatory areas, is also public records requests and media requests. We're seeing an increase in that volume, and those are many hours for each one of those. Between a standard request could be between 6 and 20 hours typically for one public records request to pull out data and prepare it and review it and have it prepared for a release. And we're receiving numerous of those per month minimum, if not per week. So this is a very critical role to allow us to also continue with our standard open data and standard internal data reporting.
Will this position help continue in our efforts to publish testing data? Right now we have the potency. Will it help us get where we need to be with total yeast and mold contaminants, helping us to de-anonymize, helping it to get it more into a close to a real-time capacity? Would this position help effectuate those things?
Absolutely. This is actually that would be one of the primary roles expected of this position, would be working on the open data, both current and expanding and testing, and as well as the medical program.
Would this person be analyzing data? In other words, look for
anomalies.
Anomalies. It's been a long day in testing.
So they would be helping with that role and be able to produce data into our Tableau environment, working with the testing and enforcement council on reviewing and doing some of the data analytics with those in conjunction with the different departments.
So this is almost, I know we say it's a data analyst, but really there's a public health component to this because it's mission critical and there's a public health component to getting this person in here.
Absolutely. One of the things we've been working with the investigation enforcement team on building out is near real-time or real-time alerts for failures, sales anomalies, testing failures, testing anomalies. That's stuff that we're trying to build out the real-time reporting so that instead of being reactive and doing the research and looking at it, we can move into a proactive notification when events occur. Things such as we've had historically in the past that, dates that are way out of, that appear well in the future or well in the past, or anything that may be an anomaly in the data, not only in testing, but also in sales. Transfers is another area that we see a lot of potential for diversion and that this role would be very actively involved in.
Thank you, Paul. I appreciate these answers. Connecticut has so all cannabis test results in Connecticut are posted to the state's cannabis brand registry. Is that something we could aspire to do, having folks on hand, meeting with obviously other, Chief Jones but we have to have more robust data is what I'm trying to get at in this.
Absolutely. And this role would certainly help us with that, partly to be able to pick up some of the bandwidth to allow myself, the Director of Data Analytics, to focus on more of those forward-looking bigger projects. And also to continue to build out our data infrastructure.
Right.
We've made some great strides in the last year, but certainly there's still work that needs to be done. To get to that level, which I think we all strive to. It is a matter of bandwidth.
Thank you, Paul. And it sounds like a crucial component to your team and to help Dr. Sarkis. My last question is, you said it was a swap. What position did we swap with?
We previously had approved it was Dynamics administrator and developer.
Okay, so still under you.
Still under IT.
Got it. Okay, so we didn't take from another department.
No.
This was all under your umbrella.
This is within IT.
Okay.
Yep.
Thank you, Paul.
You're welcome.
Commissioner.
Paul, I don't know if you had, if you said this or not, or if it's in here, but is this an internal listing, an internal posting or external?
We're gonna do this as an internal posting first. And if we don't get adequate candidates, we would go with an outside posting.
How long would you post it for?
We were thinking 2 weeks, 2 to 3 weeks maximum, because it's something we definitely would like to get filled as quickly as possible.
Any other questions?
No.
Seeing none. I know our acting ED had to leave, but she and I have talked about this position. I did have an opportunity last night to catch up with our incoming ED, mostly just to chat off hours, so he wasn't on Holliston's clock. Bring him up to speed on some of the things that all the commissioners have been doing this week, including the industry report meeting and a few other things. I talked to him about our agenda today. Obviously, he's not in a position to weigh in because he hasn't officially started yet. He said he had been briefed about the position with the acting ED.
And he had no objections?
He said he didn't see any objections
Perfect.
at this point.
Thank you.
But obviously, he also knows the limits of his authority at this point.
Right.
I would seek a motion to approve the job description for data analyst. Commissioner Camargo, would you like to offer that motion?
I would not.
Okay. Commissioner Roy, would you like to offer that motion?
So moved.
Okay. I can second that. Any other comments or questions about the job description?
I just comment if
Go ahead.
I can. I think I'm speaking to my colleagues, Paul, I spoke to you briefly this afternoon, but I have not voted on 2 other positions that have come in front of the commission, and I've given my reasons for it. And I also am doing the same for this position. I will not be voting for this position. My reasoning, and I've said it before, is that I would like for the executive director to come in, take some time, have a conversation. I know that Commissioner Stebbins, I'm glad that you're having some, after hour conversation with him, but I want to make sure that he has a moment to figure out the landscape of the commission before we put more positions up. And thank you for all that background information. So.
All right, I'll do a roll call vote. Commissioner Camargo?
No.
Okay. Commissioner Roy?
Aye.
And Commissioner Stebbins votes aye. The motion does not pass. Commissioner Camargo, you clearly stated, your thoughts on other positions that
Yes.
we've been considering, getting close to the new ED's arrival. So I appreciate that. Appreciate you committing to that. I did want to keep this on the agenda. I did want to give Paul the opportunity to at least talk through the job description with us. Hoping that we might be able to bring this back for the first public meeting in March. Again, the acting ED will have a new ED will be acting. New ED will have a lot coming at him, but I hope we can put this back on now that all 3 of us have a flavor of the position. And again, when he's here to have his recommendations.
Understand. Thank you very much. And I would appreciate the opportunity to present it again in the future.
Thank you. Thank you so much, Paul.
Thanks.
Thank you, Paul.
No new business, not anticipated at the time of posting. Our next meeting date is March 13th, which is our second Thursday of the month meeting, mostly for business purposes. We have another one on March 27th, which is a policy discussion meeting. And our March 13th meeting will be joined by our new executive director, Travis Ahern. So excited to have him join us. Commissioner Roy, have your hand up. Go.
Thank you, Chair. I'm requesting 2 agenda items. The data analyst position to be represented on the 13th and also the hot tip update from Paul on the tip line as well. Thank you.
Those are our next meeting dates through the end of the year. If there's no other business to come before the commission, I'll entertain a motion to adjourn. Do I have such motion, Commissioner Camargo?
So moved.
Do I have a second, Commissioner Roy? Second. Motion been made and seconded. Last minute comments or questions? Seeing none, roll call vote, Commissioner Camargo?
I was gonna just make a comment. I just want to thank no, it's okay. I just want to thank everyone who came to the listening session this morning, everyone who's here, folks who are still here, folks who are online, our team, and everyone who was who played a role in this. I also know that there's tons of behind the scenes folks doing things for our agency today. I know that we always get in trouble when we say someone's name and we leave other folks out, but I want to just, shout out to the team who's running the behind the scenes of online, but Paul, also to your team. You guys were troubleshooting like crazy today. So, and I just want to thank Kate Flanagan as well, and Abby there. 2 executive administrators, for 4 commissioners and an ED and everybody else. I want to just thank them and all the work they do every day to make sure that we show up and that we have our stuff in order. So, and again, to your team as well, Paul. So, and I.
Commissioner Boyd, vote, and I'm sure comments.
Yeah. Which one do you want me to do first? Comment?
Your comments first, and then you can vote on it.
I also want to thank everyone who testified, and I'm looking through my notes, and so many people had shared where they had adverse events, whether it's pre-radiated or remediated product. We had Danny Carson here talk about products failing when when they've done off the shelf testing, which leads me to stress the importance of this data analyst, and this is really about public health. So we need to get this person to help get this data out there so for the world to see. So again, thank you to everybody, and I
will make a few comments before I vote. First of all, I do want to thank Commissioner Camargo. She worked with the team to pull this listening session together. We've been trying to mix it up a little bit. So though she sits in the social equity seat, we all know we all have an obligation to support our medical program. And I think she did a great job working with the team, pulling it together, the information that was shared, and, just all of, as you call it, the kind of back of the house operations that go in to make this a successful listening session. Certainly, Paul, to you and your team for all the tech issues to make people be able to participate in these types of listening sessions remotely. Jessica in the back of the room kind of keeping me on task as to who was here and who wasn't here. Also to Kate and Abby, who do a fantastic job producing these meetings. We definitely want to get them support as we continue to do more of these. But I also want to thank the people that were here to testify, some sharing very personal stories, and how important, cannabis is to their health and their overall well-being. We take their thoughts and concerns very seriously. I'm going to spend a few hours someday going through all the notes and all of the question marks I have and all of the kind of pieces that are necessary for us to think through, again, modernizing our regulations around this program, as well as other areas that we've all talked about in other meetings. But greatly appreciate my colleagues' collaboration today in getting this done. And with that, I'll vote aye, and we are adjourned.
To Betsy and Kathleen as well.
Yeah.